known as QHOC. I'm Lisa Bowie. I go by she, her, hers. I am the Quality Improvement Director. I will introduce our chair as well. We've got Dr. Jeannie Savage from Trillium Health Plan. She is our Medical Director Chair, as well as Dr. Doug Carr from Umpqua Health Alliance. He's our Vice Chair. And then Dr. Dawn Mottner, our Medicaid Medical Director. So I will turn it over to any one of those three for our actual announcements, and then I'll run through the agenda and go from there.
Good morning, everyone. Jeannie, you're totally welcome to open, and then I just have a couple of announcements after you open the meeting.
Wonderful. A meeting is officially opened. I don't have too many comments except to say welcome everybody. Glad everybody's here. And we had some wonderful reminders from friends this morning about our focus and continuing for continuous quality improvement and working for the care of our members in our community. So I don't have anything else but that. Dawn, you're up.
Thank you.
I think we need to mute Susan. There we go.
Thank you. Good morning, everyone. Dawn Mottner, she, her, Aya, white woman, long brown hair, and I welcome you here this morning. I know that there is snow outside my house here in Portland, and that the schools in Portland, at least, are closed for the day. In which case, we may have a meeting that includes some of the impacts of that. Some people may not be able to join or have connectivity issues, and there may be littles joining the party today. Kid cameos, as Kat notes in the chat. I wanted to just make a couple of announcements. The first is in appreciation of all that y'all are doing to support care and support for our highly impacted communities. The public health emergency that has turned our lives and work upside down for the last couple of years is scheduled to end on April 16th. Today is April 11th. That's pretty soon. However, the public health emergency ending, the state has been told that the state will be given 60 days of notice, and we haven't received that notice. So we anticipate that the public health emergency will be extended again, but we haven't been told that yet. So as of now, the public health emergency is currently scheduled to end at that time, this Saturday, until we get an update from the feds. Otherwise, the state PHE stays in effect through June, to my knowledge. And the other update can wait. Thank you.
Great. So let me just give a couple of quick reminders before we get into the agenda. So please do keep your phone or computer on mute unless you are speaking. There is the little raised hand functions on your Zoom reactions button. The reactions is the little smiley face down on the menu bar at the bottom. So if you hit the reactions button, there's a little hand raise function. You can also use the chat function to express any questions. We are monitoring the chat. And when you are speaking, if you wouldn't mind, please say your name and organization you are representing. And then as far as today's agenda, we are going to be going straight into the HERC update with Dr. Ariel Smith. Then we'll be covering a 2023 CCO contract piece related to community births. Then myself and and then Tom Wonderborough will be covering the Oregon Medicaid Quality Strategy update. We will have a break. Then we'll go into the initiation, engagement, and treatment and for alcohol and other drugs, learning collaborative. That will be an hour long instead of 90 minutes. Then there'll be a lunch break. Then the afternoon quality performance improvement session will be all related to performance improvement projects. So we'll specifically speak about the integration PIP and the validation that's coming up in the summer. We'll have related to health equity presentation. We'll have a conversation around your baseline data that will be available and distributed. We'll talk about the validation, and then we'll use the last hour to talk about SUD statewide PIP design conversations. So it'll be a full load of quality conversations today. Let's go ahead and advance the slide. Ariel, you have the floor.
Thanks, Lisa. My name is Ariel Smits. I'm the medical director for the Health Evidence Review Commission, and I'm giving you your HERC update for April. Next slide, please. So we last met in March, and you've seen all of these topics before. Nothing was really significantly different than what I had kind of mentioned to you in the past. We added a couple of uncovered lines to our Botox guideline just for updates. We moved intraopathic arthropathies to a covered area. We clarified we don't cover pelvic congestion syndrome. We added platelet-rich plasma to our guideline note 173 for things that don't have any evidence of effectiveness. We clarified that we do cover breast reconstruction after lumpectomy for breast cancer for the contralateral or the ipsilateral breast. We consolidated all of our guidelines that had breast MRIs. There were 4 different breast kind of screening or imaging guidelines. We compressed them all into one, so hopefully that's helpful for you all. We reiterated we don't cover actinic keratosis treatment because it's not really associated with improved outcomes from the possible squamous or basal cell cancers that might possibly result. And then we clarified a few things for urology folks, clarified that we don't cover sensory integration therapy or gait analysis or surface electromyography. And then the polydactyly clarification was just that that diagnosis was on 2 lines. And there had been initially a proposed guideline that but the HERC had only just wanted it covered. So we removed it from the uncovered line. Next slide, please. And all of these details are in the minutes that you received. So if you want to look at any of the specific details, please, I would refer you to there. We did look at 2 things for our 2024 biennial review. So everything before that will be effective either October 1st or January 1st, depending on sort of the size of coverage. These will be effective January 1st, 2024. We're getting rid of the agenesis of lung line because that diagnosis is already on a covered line. And then dorsal rhizotomy for spastic diplegic cerebral palsy, which was already on a dysfunction line. We are removing that line to hopefully help clarify that we do cover the surgery. Next slide, please. So what's coming up for May? We had some questions about erythropoietin for non-end stage renal disease, and we're still working with P&T on that. Probably we will add it to the chronic renal disease line because it is being heavily used for codes that represent non-end stage, and we want the guideline, the anemia diagnoses, et cetera, to apply to that line. The congenital foot deformity code review was slated to come back as just something straightforward. However, I've gotten an orthopedic, a pediatric orthopedist and a podiatrist who both really want to go into detail on this. It's probably going to come back in August. We have an ophthalmologist coming to talk to us about making visual field testing diagnostic. Currently, it's on multiple lines, and she's arguing that it really should be more diagnostic. The ENT Society, whatever their initials are, apologies to anyone from ENT out there, they have updated their adenoidectomy guideline, and we are going to update our guideline. Currently, our guideline says that adenoidectomy is covered with the 2nd set of ear tubes, and the revised guideline that was just released says that it can be covered with the 1st set to hopefully reduce the amount of anesthesia a patient might need. And then we also just looking at the Adenoidectomy Guideline, because we have an ENT coming to talk to us about that. We're also bringing up bilateral BAHA. BAHA is bone anchored hearing aids. And we added a guideline almost 10 years ago to cover them for unilateral hearing loss. There's actually really evolved over the past 10 years. A lot of evidence has evolved that especially for kids that have bilateral ear deformities, that bilateral BAHA can be effective. So we're going to change some of our BAHA guidelines. Temporary ureteral stents, that should be your ureteral, not, I don't know what that word is. Anyway, there's no evidence that they're effective, so we're just going to reiterate that. Fecal lactoferrin is a test to help differentiate inflammatory bowel disease from like irritable bowel disease. We cover the qualitative code, but not the quantitative code, which is not kind of consistent with what all the private insurers are doing. So we will move to cover the quantitative code. Gastric neurostimulators, we haven't covered them to date because they are not actually FDA fully approved. They're approved under a humanitarian use exemption. We've been told that that does qualify as FDA approval for the terms of Medicaid. So we will do a formal evidence review. It looks like we'll probably cover them for diabetic and idiopathic gastroparesis with a new guideline. And then one of the big changes that you should all know about is currently we have quite a restrictive guideline about MRIs and multiple sclerosis. And it's not really that the evidence has evolved, it's the professional guidelines have evolved to the point where neurologists, the current guidelines hold neurologists to changing disease modifying therapy if there's a clinical change or if there's 2 or more new lesions on MRI. So if we continue to not cover routine MRI for multiple sclerosis, we're kind of tying the hands of our Oregon neurologists. They can't follow their own specialty best practices. And so the proposal is to just get rid of our current guideline and allow basically whatever the neurologist feels is appropriate. It's going to be a pretty large change. All the neurologists that I've been in contact with are very supportive. If you have any concerns or have any other comments, I would encourage you to reach out to us at HERC.info. And we're always happy to take your input as well. Next slide. A couple of other things. Orthodontia. I know that you guys have all been hearing about orthodontia for the debilitating malocclusions. We had some sort of automatic ins, and based on the orthodontia work group and Dr. Raffia's recommendations, we are actually just taking those out, and we're going to have just the all right, can you all hear me now? Okay, sorry, it looks like Lisa had to mute everybody, so hopefully you can hear me. We reviewed coronary CTA. This is coronary CT scans. They are rapidly becoming sort of standard of care instead of stress tests for all sorts of populations. And both of the cardiologists who are on her committees or subcommittees feel that we should have coverage, and they're recommending no guideline. So just adding it as a diagnostic test. Again, any input that you have would be welcome. The autologous Chandra site implantation, I'm working with a orthopedist about what we're going to do with that. Rhinophyma, which is the sort of end stage of rosacea for the nose. We currently have the shaving for that on a couple of lines like this chronic sinusitis line. Rhinophyma doesn't actually cause nasal obstruction. It's sort of more of an outward process, and private insurers consider it cosmetic. And so we are going to just put it on the rosacea line, which is uncovered. The inflammatory skin disease guideline update is probably going to wait until next year. NICE is currently doing a substantive review of treatments for things like eczema in kids. We're going to probably put that on hold. And then the spinal cord stimulators for diabetic neuropathies are also on our list of things to look at. And things will kind of continue to trickle in as we have a few more weeks before we'll kind of close the agenda for this coming meeting. Someone wants me to repeat what I said about orthodontia. So we currently had a guideline where there were 4 or 5 automatic things, different types of that for the different types of like really severe malocclusions that would sort of be an automatic in. And based on the orthodontia work group and Dr. Rafia, who's our dental director, we are getting rid of those sort of auto ins, and it's just going to be the score on the scoring tool that the orthodontists want to use. And then there's a question about who pays for the orthodontia. I think there is a whole orthodontia work group right now going on at HSD. Since this is severe malocclusion that sort of results in inability to like speak or chew, et cetera, a lot of these kiddos are going to need jaw surgery. That would probably go through your CCO. And then a lot of the orthodontia, the braces themselves would go through DCOs. We are still really working behind the scenes. This is not a thing that's going to go into place until January 1st. So we will keep you updated on what the orthodontia group determines. Sorry, I can't answer that better. Next slide. EBGS met last week, and the big thing that came out of EBGS is that they approved the proposal for pan-to-pans that came that had been revised based on public input. So it allows IVIG and plasmapheresis for kids who have tried 2 non-invasive therapies like antibiotics or corticosteroids or psychotherapy, et cetera, and either failed or didn't have prolonged response. And then you have to have your PCP and one pediatric subspecialist agree that that's the proposed treatment. The initial recommendation was to have 2 pediatric subspecialists. We heard overwhelmingly from our public input that would be an almost insurmountable barrier to get in to see 2 pediatric subspecialists. So we landed on 1 pediatric subspecialist agreeing with the PCP, and then reassessing every 3 months for any continued need. Still no coverage for surgical interventions like tonsillectomy, and no long-term antibiotics. We did receive a very substantial amount of public comment on this. Pan-to-pans will go to the May HERC. It'll be going to VBBS for some discussion, and then to HERC. And any changes that would come from that would probably start January 1st because of the nature of the change. Next slide, please. We had initially voted out high frequency chest oscillation devices, also known as chest vests. This had been voted out of EBGS at their November meeting. However, our contractor, the Center for Evidence-Based Policy, realized that there was some error in some of the information that they had put into the report. And with that corrected information, the EBGS subcommittee felt that the evidence was downgraded from low to very low for CF. They felt still that this was sort of a standard of care, and there wouldn't be a lot of new evidence forthcoming based on expert input for CF. So they continue to recommend coverage, but they are recommending now against coverage for bronchiectasis because that was sort of extrapolated from the CF data, but now it's even lower level of evidence. They felt that they couldn't really make that jump. It also still recommends against coverage for COPD, and then for coverage for neuromuscular diseases that result in pulmonary outcomes, mainly because these are such small groups with different conditions that would be very difficult to study. That revised recommendation is going out for public comment. So if you're interested in making public comment on that, please kind of keep an eye out for the automated emails that you get that invite you to make comments on that. We'll bring it back to our June meeting and discuss that further. We also had on our agenda scoping for 2 topics. We only got through bariatric surgery, so that scope is out for public comment. We expect to get to continuous blood glucose monitoring at our June meeting and have that out for the scope out for public comment after that meeting. Next slide, please. And then just in general, future topics for either HERC or for EBGS. We are always interested in your ideas. Next slide, please. And also, I want to thank you all. I know several of you are, or many of you are in touch with me and you point out errors that you find. We just had a couple errors pointed out last week that are going to be just straightforward corrections. Other topics are always welcome that, for us to look at. So the best way to get in touch is the herc.info address. You're also welcome to send things to me or to Jason directly. Are there any questions for me or for the HERC? And again, we're always happy to hear from you. And I know you guys aren't shy about sending emails, and we're happy about that. So please keep doing that.
Yeah, I don't see anything in there. Dr. Carr answered the one question that came up for you, Ariel, which was just repeating when there was the audio issue, which was who pays for orthodontia, CCO or DCO. So I don't think there's anything else.
We will hopefully, I'm not sure on that one, and HSD, OHA as a group will hopefully have more guidance on that in the upcoming months.
Any other questions, hand raised, or in the chat stream for the HERC or Ariel?
Yeah, the payment is probably less important than if the CCO pays for it, then we have to start creating network, identify the network. That's the issue. Yeah,
I mean, we on the OHA side recognize that there is an insufficient network currently for Medicaid. There's going to be contracting problems, how to review claims. And I mean, we realize there's many pieces to this. And I believe Dr. Rafia and the Orthodontia work group are working on lots of issues. So I'm sorry, I can't give you a clearer picture.
And this kind of leads into, in future years, orthodontia, whether it's related to the expanded coverage that we need for children, for under age.
So the current guideline is just handicapping malocclusion, which is very severe. Right. These are kiddos who you may already be covering because they are severely affected. And then, you're already covering it for cleft lip and palate diagnoses, that kind of thing.
Thank you, Dr. Carr. Can I just do a quick check? Dr. Jeannie Savage, are you on the line? You may have had a technical difficulty, but I don't see anyone in the waiting room. So I just want to confirm if you are still with us.
This is Jeannie.
Okay.
Yeah, this is Jeannie. I made it back in.
Okay, thanks, Jeannie.
Thank you.
Any other questions for Ariel?
Sorry, I have pets and kids and all sorts of things going on in the background. It's a day.
It's a day. Who knew we were going to have snow in April? And I'm not even in Oregon. I'm down in California.
And where we live, snow is a stretch. We have some slushy, whitish stuff in between the blades of grass.
Okay. And I am dealing with some family stuff in Southern Oregon or Southern California. So I'm hot spotting. So let's hope technology goes with us for the rest of the day. Okay, thank you very much, Ariel. Obviously, you have Ariel's information. As always, please send it to the HERC info if you want to get it to Ariel or Jason, and one of them or all of them will get back to you. Oh, wait, she thought of something else.
Oh, I realized that we have a new a medical director that's starting, but she's not starting officially till next week, so I can't introduce her. So sorry, that'll be next month. That'll be your exciting thing to look forward to.
She's just giving you a teaser right now. That was so funny. that was just a little bit of a hint. So in May, you're gonna get an introduction. Okay, thank you. Okay, let's go to the next slide, please. That's very funny, Ariel. You're so cute. Diane, are you on the line? And Diane, if you're trying to unmute, you might want to try *6. We're not running ahead. Dawn, do you want to try and ping Diane?
Sure.
Cheryl Henning, are you on the line? Hi, Cheryl. Thank you for confirmation. David, are you on the line? Cheryl's pinging Diane too. Let's go back a slide, please. There's Diane. Welcome, Diane. And Jennifer, you go back a slide, please. Thank you. Okay, I'm Dawn. We've got Diane. I'll go ahead and pass it off. Dawn, do you want to introduce Diane in this conversation?
Sure. As many of you know already, Diane Quiring is one of our wonderful policy analysts at Medicaid, and she in particular has been supporting the out-of-hospital birth or planned community birth work, which has, as you know, garnered quite a lot of attention over the last several years, especially. This is a response that she has developed to a request that came from CCOs, and Diane, I'll turn it over to you. I'm here to support you, and I'll slip in when it's my turn.
Thank you, Dawn. Good morning. As Dawn mentioned, my name is Diane Quiring. I use she, her pronouns, and I work in the Medicaid program unit. So what we're here today to discuss is a concept, again, based on some interest from CCOs, around how we might move forward with having CCOs include planned community birth as part of their coverage benefit. So next slide, Jennifer. Just to sort of give some context here. So as we've kind of transitioned our language to planned community births, it's in contract, it's referred to as out-of-hospital birth, or abbreviated OOHB. And just to kind of describe what that means is that certainly these are births that members might select or choose as their birthing location other than a hospital setting. These include the freestanding birthing centers. These are birth centers that are licensed by the OHA public health divisions, healthcare regulation quality improvement program. I think I mistyped the abbreviation. It should be HCRQI, not two Q's there. And then I provided a link of where you can find, well, where are those currently licensed birth centers here in Oregon. These planned community births can also take place in a private home, so individual homes for OHP members or other private homes, as well as possibly in some individual practice or office locations. but the first two are probably the most common choices. And currently, there's a variety of birth providers that can provide these planned community births, including various physicians. So naturopathic physicians, osteopathic, allopathic physicians, in addition to certified nurse midwives, which are advanced practice nurses, and licensed direct entry midwives. So certainly CCOs may already contract with a variety of these provider types that I've listed here, but there may be some, for example, licensed direct entry midwives that are not currently licensed by CCOs through their networks. So what we're talking about is if a CCO wants to bring planned community births into their coverage, this proposed contract amendment would allow CCOs to do that if they choose to do that. And certainly what we're looking at is how could we do this with the 2023 sort of mid-year implementation. So if a CCO expressed interest in adopting this amendment, then a specific contract amendment would be written for that CCO and would be in effect beginning July 1st of 2023 and run through the end of 2024. So an 18-month sort of pilot, you might call it. So it doesn't require that a CCO adopts this for all community birth providers. It would be just those community birth providers that the CCO has contracted in their network. Let me look up my notes. Okay, next slide, please. Thank you, Jennifer. Well, I already talked a little bit about this. I guess I was talking before getting to the slide. So again, as I mentioned previously, this would be a voluntary opt-in. And, I think what we would be looking for is for those CCOs that have an interest to maybe express that interest to OHA by early 2023 so that a contract amendment could be drafted. This would allow, again, for CCOs to cover planned community birth services for those qualifying members who establish care with a community birth provider that's in the CCO's network. For a number of years, we've been handling planned community birth requests as a carve out so that those services are covered by a fee for service. If a member was selecting a community birth provider that was not in the CCO's network, we would continue to handle that as a fee for service sort of carve out. And as I mentioned, the amendment would continue for 18 months through the end of 2024, which is the end of the current contract award. So it's not an all or nothing kind of scenario where CCOs would be required to provide or enroll providers that they're not currently enrolling in their network. It would just be those network providers that they have enrolled who want to continue that continuity of care for those members who are choosing a planned community birth. Next slide. So I think I'll pass this off to Dawn. She wants to talk a little bit about what does that look like in terms of that CCO member who is selecting a community birth. So take it away, Dawn.
Thank you, Diane. If we say voluntary and opt-in more often than you think we need to, you can let us know, but we've heard enough concerns from those who are not enthusiastic that we want to be sure that you know that this is an opt-in and voluntary in response to a request, and it gives us an opportunity to explore what it might look like in cases where the community-based provider is able to contract with their CCO, and how that care coordination might do a better job of meeting members' needs, because it doesn't disrupt. You don't have a whole new team of care coordinators trying to come in and make connections through KeyPro or the fee-for-service team and so on. You all know that better than I. In any case, for these cases, the questions about whether initial prior authorization and or concurrent review continue to be processed by or through OHA, or whether they go through the CCO, is an outstanding question. We could certainly do it at OHA, and that might maintain a more consistent process for all of the OHP members across the state who are pursuing a community-based birth. But my thinking is that those CCOs that have proposed to participate in this and that have requested this opportunity probably have their own processes that they would like, that you all would like to put in place. And so that's a conversation, a discussion that I would like to open with you to see what it is that you would propose, what would your preferences be, and how can we streamline the process and make it most effective for the people who are trying to have births in a system that is not nearly as well developed here as our hospital-based births.
Hey, Dawn.
Yes.
This is Jeannie.
Yes.
I was going to say, yes, there's some questions popping in. Jeannie, are you going to field those, or would you like me to help?
Tell you that I'm only on the phone. I do not have access to the Zoom, and I can't see any of that. So
okay.
I will have to have you all address those questions since I can't bring them up. I would like to hear originally when the request came through, I heard just references to continuity of care, but I guess my question is in doing the amendment and not just waiting until 2025, what is the problem that we were trying to solve, or what does this voluntary for a few CCOs, or if we're not all doing it together, which I think creates confusion for members across the state. I guess I'm trying to clarify what exactly is the problem we're trying to solve.
So I wasn't in the room for those conversations. They have taken place without me, the initial asks. I have supported the opportunity for CCOs that want to do this to investigate what it could look like. And it is clear to me that the disruption associated with carve-outs in general as a process engender confusion on the parts of members within that process for anybody who's going through it. So if anybody on this line would like to speak to that, it seems clear to me that carve-out itself it's something we can do if we need to, but it's not an ideal process to maintain the trust and rapport that care coordinators build from between the CCO staff and the members, and that needs to be drawn upon when people in these processes need services that they're having trouble putting in place.
This is Diane querying again. So I'll just add that, and I put this in the chat as well, that it was Care Oregon who reached out and expressed interest in being able to offer community birth for their members. And again, the current contract, so to your question about what are we trying to resolve or solve, is that current contract language has it listed as excluded. So it's not currently an option for CCOs to be able to include community birth coverage. And as Dawn mentioned, it's sort of mandated that if a member is going forward and is approved through our OHA fee-for-service prior authorization process, then we deal that as a carve out. The members' other medical needs continue under the CCO. It's just the maternity care and delivery that is carved out. But again, there can be the potential for disruption of care overall by doing that sort of carve out of just those services. And I think I might be able to address a few things. Let's go to the next slide, Jennifer. So again, sort of why do this now? Again, just sort of still historical context. So we began the just having the carve out back in 2021 for those members who were approved for community birth. Prior to that, we disenrolled them entirely. And so that definitely was some disruption of care. And I see Doug's hand up. So let me just finish a couple little other bullets. As I mentioned, since then, some CCOs have, specifically my recollection, it was Care Oregon, that expressed interest in being able to cover that, perhaps at birthing centers. And so this proposal, this concept was developed as a way to support those CCOs who are interested in this and maintain the current process for those who want to continue to just handle the maternity care as in a community birth as a carve out. When we looked at some of the data, come back up my notes here. This was based on 2019 data. There were roughly 14,000 births of under CCOs, and the community birth was about 1% to 2%. So it's a relatively small number, but from an equity lens, we believe that this can help improve access and again, maintain that sort of continuity of care. Okay, maybe we'll pause for Doug's question.
Thanks. Can you hear me?
Yes.
Yeah, thanks, Doug Luther from Care Oregon. So it's interesting. I'm not disputing somebody from Care Oregon may have asked for this, but interestingly, the two senior medical directors on this call are not aware of a request, and neither was our attorney who's also on this call, but probably somebody from maternal family or maternal child team probably requested that. We were actually doing this, as you know, a couple of years ago, and I think we had drafted some pretty specific criteria for who would qualify to be in our network. And then I guess the contract changed, and so we weren't allowed to do that anymore. That's our understanding. And so I'm actually getting clarification right now as we're talking. We didn't ask, we were clarifying what the rule was, and OHA offered to bring it up later. So I think there's some miscommunication about whether or not we actually asked for this or not. We do have some concerns, but we actually were doing this with a contracted birthing center that's physician run that we were confident could deliver high quality care. But I think as a larger concept, we have some concerns about starting down this path and what might end up being the end result. So I just wanted to clarify that.
I hear you loud and clear, Doug. Those concerns are raised pretty regularly around this conversation, and I appreciate your articulating it here for consideration. I look forward to the conversations in which we're able to look at the last sort of decade of how this policy has been, how it has been put into place, and what the processes have been, where we are doing a good job of centering equity and where we're not, and how the outcomes can inform sort of a best practice and policy. So there's some good conversation to have here, and there are no requirements at this time, and this is an opportunity for those who want to put it in place to help figure out how best to put it in place and provide the standard of care that you are able to define as appropriate for your members.
Yeah. Hey, Dawn, this is Jeannie. And to that point, I think it's important that we have, I think that's an excellent invitation that for us to be at the table for those discussions. I guess I get a little confused as there's a parallel process happening in the RAC around the planned community births as well that's taking place. So I just want to make sure, and I don't think that on that RAC there is a CCO. I'm not sure, I haven't looked at all the members, but I'm not sure that there is a CCO representative on that RAC. So yeah, I just want to make sure that all of the processes that are taking place are happening contiguously and aware of each other, so that we're all on the same page in hopes of going forward with a successful implementation and so forth, however that may look. And I'm not sure that we're at any of those. I'm not sure to what extent we're at that table. Does anybody know? I'm not sure. Somebody can clarify if that would be helpful. It would be helpful for me.
Probably that falls to Diane mostly. Please be aware that there are two RACs because there are two different relevant policy groups. One is public health because of their licensure responsibility for the birth facilities, and that's a separate location and conversation than the one that informs the Medicaid policy that describes the CCO and fee-for-service coverage combination. Diane, do you have more on that?
Yeah, sorry, my connection dropped there momentarily, so I missed part of the conversation. But yeah, certainly, our in terms of rules advisory committees meetings, we make an effort to inform all the potential stakeholders, including CCOs. But I guess I missed the whole question about two specific RACs, and I'm not sure what you're referring to.
I just noted that there are two specific RACs with different frames that they discuss relevant to each other, but not mutually informing each other's requirements in the same way. But the concern and question that was raised, Diane, is that there are parallel conversations going on in different places, and that one, the CCOs be in those conversations, and two, that the different participants in each of the conversations be aware of each other and what those conversations are. And then it was important to me to invite them to the table. The CCOs need to be in the conversation. And then it looks like we have another couple of hands up. Doug, I think you had your hand up first, Doug Luther. I'm not sure if that's left up from before.
Yeah, sorry, that's left up from before, Don.
Okay. Safina, I think you were next. Good morning.
Sorry, it took me a second to get off of mute. So of course, I agree with everything Doug said regarding Care Oregon. And to answer a couple of your questions regarding what concerns would be, and then also your PA thing. So first, I think from a Care Oregon perspective, obviously we see the benefit, but we really feel that what we didn't know, to Doug's point, is recently, and nor did our legal department know, that it was excluded. So that'll be something that we need to look into. So that's something that I think all CCOs in current state need to have that very clarified. Is it not allowed is the first clarification point that everybody needs, and probably in writing. And number two is, if it's not allowed, then it's not allowed, because I don't think that there's going to be many CCOs that are going to opt in unless we're allowed to have very strict criteria that we choose, that we feel comfortable with in terms of safety and clinical quality. And that will be like the question there then that would need very specific clarification is in terms of location and provider type. Are we able to make, we meaning CCOs, able to make our own policy choices, or if we choose to do this, or if when we're mandated to do this, if that ever happens, are we mandated to allow for all the provider types, et cetera, including LDEMs, et cetera? So that's one clarifying question that I think everyone's going to need to know. And what is current state, what's that? And then the third thing is gets to your question about PAs and HERC criteria, because current HERC criteria is great, I think. And, all the work that was done by the HERC on that. And the OHA PA process is good. I would support maintaining that systematically if this ever does change, just for at least in the interim, at least for a while, because I do worry about the degrading of HERC criteria and like VBACs and all those things, for example. So those are three major things I think need to be clarified for us to have more concrete conversation.
Thanks, Safina. That's helpful. I think what I'm hearing is, one, it is excluded now, and the rule change that we're talking about today is what makes it not excluded. You can do it with the providers you want, in the locations that you want, when you have been able to work through your contracting opportunity process, credentialing, all the things, to determine that it's a birth that you want to support for your CCO. Making it not excluded is the point of today's amendment, the one that we're talking about now.
But in order to do that, is that the opt-in thing that is that what the opt-in thing is?
Absolutely.
Okay.
None of it is blanket. It's only on an individual provider contract basis for any given CCO that wants to work with a specific provider at a specific location. Opt in for that one only, and the rest continue to come to us at fee-for-service for consideration under the same criteria, same process, same carve out. Good, clear?
Dawn, this is Jeannie. So in terms of equity, then all Medicaid members would still have access to a planned community birth through this process. And the decision as to whether or not a planned community birth was appropriate would go through PA with the state bill. And so the state is still following HRC guidelines in deciding when an planned community birth is appropriate. And so really the only difference is, and KeyPro still continues to manage case management, and CCOs continue to pay all of the labs and ancillary work and so forth. It's just the delivery and the provider that are actually carved out. And so there's no, in terms of equity, all Medicaid members would still have access to all of the basics. It's just allowing certain CCOs who have current contracts to pay for those deliveries, and if they have engaged CM, they can stay engaged, even though currently our CMs that do, like, for instance, our Start Smart for Baby, they stay engaged if the member has a planned hospital birth as well. It's not like people, we don't say, no, not anymore. You know what I mean? Like, so I guess it just allows, in a relationship to pay for it.
And to participate in that care management through it, if that is what they wish to do. Yes, that all that is available now continues to be available. And there's this option for CCOs to take that part and manage it if they want to do it differently than we do it, as long as the same criteria are met for HRC and so on.
And currently, case management from each CCO can be involved with their members, even if it's carved out. We work with KeyPro.
Yes, and the addition of the KeyPro care management entity, sometimes it works, often it's challenging, and that whole dynamic is one that would be up for discussion in a case like this, where the CCO is taking over for that particular with that particular provider, if you have a contract now, or if there's somebody that you would like to contract with for planned community-based births.
Okay.
Good.
And then my last clarification, is if you could clarify the 2 racks. Going back to that, I'm still confused as to how they're, I know you said 1 rack is owned or kind of works with public health because public health oversees the facilities that do a planned community birth, like a birthing center. And then there's another rack which deals with CCOs and coverage. Am I clarifying that correctly?
Diane, would you like to speak to that, or would you like me to try again?
I can take a stab at it. So correct in that, yes, the public health division has had sort of an ongoing, it was disrupted by COVID, but they've had an ongoing rules advisory committee meeting that is specific to birthing facilities and what's required for those. It includes, I think, some review not only of the actual physical facility requirements, but also it includes the risk criteria that birthing facilities utilize, which certainly reflects much of what the HRC guidance is. But they have some additional, I think, lens for that. In terms of a separate, the other, rules advisory committees that I've been involved with are more from the fact that community births are part of what we offer, and that's a federal statute that we have to offer community births to Medicaid recipients, as well as ambulatory surgical center services. And so we meet that currently through this fee-for-service carve-out. This just has another option for that. And I think in terms of the contract exclusion language, I think, that was part of, perhaps an oversight, but it is in the excluded section of the contract for CCOs to not be able to offer that. So this again is just a way that we can allow CCOs who are interested to do that within their established networks with their providers of choice and locations of choice. And if a member is working with another birth provider that is not in the CCO's network, then we would just handle that with our fee-for-service as we're doing now. I know
So
we're running
Diane,
over, but go ahead.
This is my last question, but you said something which I just want to clarify. So in the public health realm, where there is the oversight of the facility, the physical facility, and the risk criteria that birthing centers and facilities follow, we could get into a position where that criteria would not be the same as the HERC criteria. Then is that a possibility that those would not be the same criteria?
There is, because the facilities and the scope of practice for the practitioners is broader in many cases than the OHP covered services, which is not different than the rest of our providers. But we're going to need to wrap here and move on. I know that Stick has a question and there are some in the chat, and I'm absolutely happy to have the rest of this conversation. But let's start to bring it in now so that we can move on to the other items on the agenda, and we'll collect all this up and answer the questions as best we can. Stick, please.
Yeah. So hi,
Sounds
Stick,
great.
Network and Health Equity Director, All Care Health. Trying to see him. A lot of this I would really defer to Kelly Burnett, our Chief Medical Officer, before I get into it. But I'm highly concerned though, related to language around equity, and I'm dropping the Oregon Health Authority's definition of health equity in the chat box here. And the reason why I'm really concerned is that when we look at systems of oppression and inequities within our society, the law of generality or one-size-fits-all approaches protect positions of power. Right now, when I'm thinking of positions of power being facilities that are being exclusionary to BIPOC women, and that's why they may be choosing these out-of-hospital births, or what these different cultural differences might be, or why they're choosing these facilities. And so I really would like to know, if we're moving forward with this, when we say equity, what is the data that's showing that there's, and this doesn't have to be hard data, right? But some data from the community about this. The systems that we've designed to be equal for all, which I'm hearing equal here, I'm hearing equality, I'm not hearing equity. And the best for the majority very clearly disenfranchise large segments of our populations here in Oregon. And so I'm hoping when you look at this policy change, first off, as I heard, was the law. There's some pieces here about how OHA has to offer this as part of the law, but how is this policy affecting different people, and how are those policy practices affecting different people? I'm also curious, which I know you're not going to be able to answer here, and we'll have to have a follow up, but who with OEI is everybody working with on this policy decision to see, as we talk about equity being part of this, where they have a really good policy analysis review tool over there, which regional health equity coalitions you're working with, the kind of community input that was there. And then not only all of that data, but I would love to see something related to fee-for-service outcomes based on real D data compared to the CCOs, and who is going to these out-of-hospital births? Is it really certain communities that are choosing them over others? And that is the preference that's here, and what are we trying to do? So I get very concerned when equity is thrown around and it's not following the definition that I put in the chat box there, and also those that are the experts on equity are not brought into the room to talk about it, and then the community to have the input. I really do appreciate Care Oregon's comments and where the ask comes from. But I do think the OHA has a burden of proof of community input and what community is looking for, which I'm also sure was part of Care Oregon's request related to this and looking at it. But it's really easy for us to talk about this and not have what the members actually want to be incorporated. So I'll stop there.
Thank you. I appreciate that. We are going to have to wrap this now. There are clearly many more questions than we're going to be able to address in this time frame. Safina, I see that your hand is still up. That may be from before. Doug Carr, I see that your hand has just gone up. And Stick, I love your question and your concerns, and I look forward to more of that conversation. It's exactly the conversation that we need to be having. I can answer some of your questions in the affirmative, others are not going to be answered in the affirmative, and it makes me want to go back, examine the process, and start to bring in some of those other things as well. So thank you for that. And Doug, final one, please.
Well, I'd like you to answer the question that Kevin raised. So you mentioned the federal language for auto hospital births. We have to do that. But do they reference provider types? Can it be, does it have to be someone qualified or someone who took a weekend course?
Every CCO will be able to choose the provider or providers with whom they wish to work. They will not be working with people without a license type that they don't want to work with. Then none of that is being forced. This is an opportunity to do what you want to do and not do what you don't want to do in terms of partnerships. That's all this opt-in is. It gives you an opportunity among all the rest that will continue to come to us.
Well, I know that's what the opportunity is, but what is the federal language? The federal language describe, reference particular provider types that need to be included?
I'll have to take that question with you offline. Yeah.
All right. Thank you. Thank you.
Yeah.
Okay. I'm going to do what I do best here, hopefully. What I heard is there's an equity part. Don's got that one. We will get the rack information, Bilbuska. So there's, like we mentioned, at least a couple racks. There's the rack related to the birthing facility, the facility part. Then there's the rack regards to the policy part. That's the health systems division part. So we will get that information. I will put it as an action item to one of our normal QHOC follow-up emails. Then there's the whole conversations about who gets to do the credentialing, what's the rule, what's the federal requirements. Diane and others will look into that. So those are just some of the questions that were put in the chat. We'll round all that together between Diane, Cheryl Henning already wrote some of the bits about the 2025. We're not even talking about that, but we'll put those answers into the follow-up email so it's just kind of all together. And then we'll see what other questions are in the chat string that we didn't even get to related to this conversation, and just have one heck of a QHOC follow-up email. And some of it may be answered, and some of it might just be the hanging, the hanging chads, in which it will just be in follow-up ones after that. So we are now going to transition, and thank you for bearing with us. And we might be eating to the break and eating into Learning Club, because I know we're going to all need a stretch break at the very least. So just let's be flexible with time. Let's go ahead and move ahead in the slide deck. So again, I'm Lisa Bowie, Quality Improvement Director. We are now going to transition to what's called the Oregon Medicaid Quality Strategy Update. And Doug, if you wouldn't mind just lowering your hand, only because then when you raise your hand for this next presentation, then I'll know you have another question. So let's go ahead and go into this next presentation. Tom Wonderbro. Tom, if you want to go on camera and introduce yourself, then we can roll through this next part. And your mic is muted still. You might have to hit *6. Still muted. While you're figuring that out, Holly Jo, I see your comment. We'll probably have more than enough time in May to talk all things out of hospital birth. So I'll put a chunk of time to wrap up. Well, probably not wrap up, but just to continue the out of hospital birth conversation. Tom, are you there?
I mean, do you really think that? I mean, I'm just maybe QHOC isn't the place. Maybe we need a separate 2 hour.
I will talk to the chairs.
Dedicated
I'll talk to the
meeting.
chairs, and I'll talk to the chairs and Dawn and Diane the policy. Tom?
I mean, I'm fine with dedicating all of QHOC, but it would need to be the entire, 10 to 12:30 time frame, and then we don't talk about anything else.
I won't be at the May one, so hey, have at it. Tom?
Hi, I'm Tom Wonderbro. I'm a policy analyst in the Health Systems Division of the Oregon Health Authority, dedicated to managing our 1115 Oregon Health Plan waiver and also joining Lisa in our quality strategy work.
Well, I will probably go through many of these, and Tom is a subject matter expert, like I said, with CMS and many of our waiver and other programs. So I will lean on him in some of the details if y'all have any questions. But let's go through these slides and get to any questions you might have. Next slide. So first off, we're going to just go some basics. What is a quality strategy? Quality strategy is a plan for direction and priorities for Medicaid, for OHA, CCOs, fee-for-service, about improving and ensuring access for the Oregon Health Plan members. Can you all hear me still? Okay, hang on.
Yes.
Yes, I can hear you,
Okay.
Lisa.
AirPods went amiss. It is federally required for all states to actually have a quality strategy, where you all in the CCO plans have what's called a transformation quality strategy. The states all have what is called just a quality strategy. It's not called a transformational quality strategy, it's just called quality strategy. Next slide.
Lisa, this is Jeannie.
Uh-huh.
For some of us on the phone only, can you tell me what slide you're on? So I can
22.
keep up on my own.
Not a problem.
You're on 22?
Slide 22. Mhm.
Great, thanks.
What is the scope of Oregon's Medicaid quality strategy? So basically includes everything. So it includes primary care plans, includes CHIPS, so child health, it includes adult, it includes Oregon's 1115 waiver, it includes the transformational goals, it includes the SUD waiver. We do have several other waivers. So for instance, long-term care services is a different waiver, it's a 1915. Basically, there is another quality strategy that's attached to the long-term services. So for now, that will remain separate, but at some point we may merge some of those strategies and goals in the future. But otherwise, it's inclusive of all services for Medicaid members. So that's kind of the scope of this quality strategy. Next slide, which is number 23. I wanted to give you the context of the current Medicaid quality strategy. The existing quality strategy was approved by CMS through our 2018 CMS 1115 waiver. It was actually attached to the actual waiver negotiations and then approved through the subsequent attachment. So it's called Attachment H if anyone is looking at that particular link. Then subsequently, a state is supposed to update and refresh, because again, you don't do this every 5 years. You have it be a living document. We updated it in 2021, so just last May, and we updated it to bring it in a reflect with the OHA agency 10-year strategic goal with, our equity work, Oregon Health Authority's 10-year goal to eliminate health inequities by 2030. We also brought it to be current with the CCO 2.0 priorities, the 2020 to 2024 State Health Improvement Plan, and also the most recent Managed Care Federal Code of Federal Regulations Managed Care Rule updates, and then also the quality payment programs that have most recently kind of come up to be. It already had some references to the hospital work that you'll be hearing about today, but we also brought it in accordance to the MET program that the CCOs are familiar with. Next slide. What's to come? So basically in 2022, so we're in that right now, the Qualified Direct Payment Program, otherwise known as QDP. We received some guidance from CMS late last year and early this year. So we're going to be giving you the updates about what's going to be coming in those changes to the quality strategy for the state. And then we will continue to work with CMS on the 2022-2027 1115 waiver. And then upon the negotiations of the waiver, then the quality strategy will then be updated again. When into next year, 2023, we anticipate making those quality strategy updates upon acceptance of the 1115 transformational waiver. And then we'll most likely make updates again based upon the qualified direct payment negotiations that will happen later this year again. And then we'll look into that alignment with the 1915 waivers for our long-term care services. And then into 2024, we anticipate making quality strategy updates related to our health equity quality metrics committee that is proposed in the 1115 waiver, but as that implementation, again, pending approval with CMS, we anticipate making those alignment changes in 2024. So you can kind of see the sequences of how the quality strategy will change pending the negotiations and then the implementation of various different pieces. Next slide. Okay, so one of the pieces really relates to the qualified direct payment. So I'm going to give you the elevator speech around QDP. And so for some of you that are in the CCOs, you may not be as familiar with this, which is okay. It's really related to probably more the finance side of CCOs, but really the essence is it's a payment program within for Medicaid members that is around hospital-based care. And because this is a quality health outcomes committee, the payments basically all go, and I'm sure the people within your CCO who manage the money side of the shop, they probably are fully familiar with this QDP. But because the money relates to services rendered in a hospital, how we connect the payments and services to quality is what CMS is really talking to the agency OHA about now. So I'm giving you all a primer and what QDP is, because that's some of the changes that we have to make to the quality strategy. So here's your elevator speech around QDP. So in 2022, Oregon received approval for the QDP. It's basically for rural hospitals, $146 million program for the diagnosis-related group hospitals that are otherwise known as BRG hospitals. It's $572 million. For the public academic medical center, OHA hospital, it's $530 million program. And then we're still working through, but there will probably be some type of privately owned ambulance program. And I don't know exactly that amount, but in the past we've had it for 2021. So you'll see there's particular measures that we had for kind of a transportation program. So at a glance, you're looking at close to or a little bit over $1 billion of payments for Medicaid members for these related services in these particular hospital programs. Next slide. Changes to the QDP, so changes to the qualified direct payment programs in the quality strategy in the QS. So dialogue with CMS in the 2022 negotiation applications basically said for our 2023 applications, they want us, OHA, to update the quality strategy to really direct those payments. So basically the payments for those services to more specific kind of like SMART goal objectives in the actual quality strategy. So where we might have, improve hospital-based care, we have to tie it toward more of a SMART goal objective instead of just improve hospital-based care. So those are the conversations that we'll be having over the course of the next few months across these meetings, as well as other meetings, to really hone in on those quality strategy goals and objectives. And that will be part of the process to get us an updated quality strategy related to QDP in preparation for our QDP preprint application. And essentially, these 2023 preprints is like the way in which we apply for the QDP. Next slide. I'm pretty basic. Yeah.
This is Jeannie. I would put this in the chat, but I apologize. I just don't have any way to connect.
That's
when
okay.
You say the first bullet on the that last slide, which was 26, I believe. that says each directed payment must be expected to advance at least one of the goals. When you're talking directed payment, you're talking from the state to the CCO. When I read directed payment, or what are those? Where are those payments going from and to who?
That's why we have a phone a friend, Tom.
And
So
sorry to
they're
interrupt, Lisa.
That's okay.
The answer is slightly different for each payment arrangement, but for each payment arrangement, we've defined a provider class. So it's from CMS's perspective, it's a set of providers that are responsible for providing certain covered services to all coordinated care members. So those are the providers who are ultimately receiving a supplemental payment, and that payment is directed by the Oregon Health Authority, and it actually sort of passes through CCOs. It's not technically a pass-through payment. That's a term that CMS uses differently, but it is a payment that supplements providers based on the services that each of those providers provide to CCO members. Does that make sense?
Yes, I think so. Thank you.
Not a problem, Jeannie. So the next two slides, and we won't necessarily go into each one of these goals and objectives, but basically for the past, and again, it's to say that in the past, these have been what we have already reported to CMS. So they've been a part of the quality strategy already. This is existing. It's been what's already conveyed, and actually, has some information and data. So each goal and objective is for each category: rural, DRG, public, and again, that transportation one. Next slide has actual. Oh, hang on, my computer is having a hissy fit. Let's go to the next slide, please. Has the measures. And then what we're going to be opening it up here for next slide is, this is basically what I've been saying all along, which is looking ahead. CMS is urging the states and us to really tie it to quality. What we don't know is the guidance going to be even more clear, I guess you could say, or consistent, that does it have to be tied and risk-based? We don't know. What we do know is at this point in time, CMS is saying, update your quality strategy to, in essence, have those measured goals and objectives really be smart, tied towards the specific payments, and very clear in what targets that you plan on achieving in X time period. That's the smart parts: specific, measurable, attainable, relevant, time-based. So that's one of the things, next slide, that we will be doing in the next few months. By October of this year, is that I will be talking throughout this meeting, QHOC, as well as other meetings in regards to specific goals and objectives from those measures and or new measures to update this quality strategy. So the measurement different than quality metrics. I'm just reading Safina's message. We can go back 2 slides, or we can go back 1 slide to look at the measures. We can go back 2 slides, or 1 more slide. Sorry, Jennifer. Right now we have avoidable ED utilization. We have follow-up after hospitalization for mental health. Those probably sound very familiar to you in the CCO world. We can be consistent and use those. We can build on those. We are open for conversation with what experience and what measures for your community make sense, and what disparities you're seeing in your communities. So this is not the end of the conversation. This is the first of the conversation. And somewhere at the end of the slide deck, you will notice there's multiple meetings, and there will be continued conversations at QHOC, this meeting, the second Monday of every month, because this is the quality committee meeting for Medicaid, this is the quality strategy for Medicaid. So this is why it will come here regularly. That is QDP, quality strategy update, elevator speech, as quickly as we go. So I'm going to open it up. I'm going to do a quick Jeannie Savage check-in as our chair. We technically have a learning collaborative. We've run behind due to community birth conversations. How do we want to do an adjustment of our calendaring agenda? Because we do want to have, we probably have some public engagement around this conversation. We do probably want to be respectful of people and have a break. And we do want to have a learning collaborative. So how would we like to adjust?
I would, yeah, this is Jeannie. If you're okay with this, I think I'd give people 4 minutes really quickly, get up, stretch your legs, grab some coffee or water, whatever you need to do. Meet here. My phone says 11:31, meet at 11:35, and then go into the learning collaborative and maybe do, it looks like that's a full hour, correct?
Mm-hmm.
So maybe just 55 minutes instead. So let's take a quick break and come back here at 11:36. Give you 4 or 5 minutes. 11:37, 5 minutes. Does that work? And then start our learning collaborative.
Okay. And then if anyone has questions, you have Tom and my information about the engagement around the quality strategy. We will meet here again at QHOC. If you literally say, Lisa went really fast, what the heck is this QDP? Or you have thoughts on what measurement you want to propose for the changes, then please let us know. And we will talk more in May about the updates to the Medicaid quality strategy. Again, our date that we will be having it up for public comment will be no later than October 1. So that's my drop dead date. Is that correct, Tom? Did I get the date right?
That's correct. Yes.
So we will be engaging through these committees, the Health Equity Committee, the Medicaid Advisory Committee, and then throughout conversations in the summer and leadership internally and externally between now and September, between now and Labor Day, basically. Okay, everyone take a good 5-minute stretch break, and we'll see you back for the Learning Collaborative. Frank, this is Lisa. Do you happen to be there?
Yeah, I'm here.
Great, thank you. Jeannie, are you back?
Yep, I'm here, Lisa.
Okay, well, I'm just gonna go and just hope everyone's back. Okay, we are gonna get going with our CCO Learning Collaborative. I'm gonna keep the introductory remarks brief since we are running a little bit behind. This is the Learning Collaborative for initiation, engagement, and treatment for alcohol and other drugs. I will go ahead and kick it off. Let's go to the next slide. So for the Learning Collaborative, we'll do a quick welcome and overview. Like I said, I'll just go pretty quick. We will do a review of the actual measure and the specifications and current CCO performance. We'll do a brief overview. Dr. John McElveen will do an overview of SUD on the health and utilization and the importance of IET. And then we have fortunate enough to have 2 clinic experiences with the IET measure, and they'll bring to the conversation around barriers and strategies. We have Multnomah County Health Department and Virginia Garcia Memorial Health Clinic. Those are both federally qualified health centers. And so we are happy to have them both at the table. We also have some information in the actual meeting packet from some of our partners down also in the Klamath County region. So let's go to the next slide. Well, one of the things I want to bring back to you all around this, and I'll let Frank address the whole measure stuff, but we basically talked about IET. So it's called Initiation Engagement. The acronym is the IET measure. We talked about IET being the Learning Collaborative topic before the pandemic. So it seems like a lifetime ago. So 2 years ago, which is just kind of a little bit odd. The IET measure came onto the incentive measure list, and we thought about the complexity of this measure and the care coordination that is required around this measure. And we said, let's put this as our Learning Collaborative topic. We're going to have it at the beginning of 2020 and then pandemic. So when we were revisiting bringing about a Learning Collaborative, the quality folks still felt that this would be a great topic to bring because of the complexity of the care coordination and the measurement. And so here it is. So let's learn from our partners, look at what the measurement is at, and I will turn it over to Frank to talk about kind of the measurement itself, then talk why this measure is still important with John, and then John will turn it right over to the clinic. So Frank, you've got the floor. Frank, you're on mute. Frank, you might have to hit *6 or something. Love the glasses, by the way. Still on mute. It's *6, right? I think that's what we're supposed to try when. Nope. Frank, I'm gonna let you figure out your sound, and maybe we'll switch ahead and let John give the why is this measure even a measure, and why does IET? I don't know why Zoom is not being your friend right now, Frank. Maybe you can try calling in from the phone. Jennifer, can you advance a few slides up to John's slides for us, please, while Frank figures out his sound? John, are you okay to go?
Sure. I thought I was going to have the same problem as Frank, but I found the mute button.
So we can hear you, and let's go ahead and just have you kind of lay the stage of the importance of this. So thank you.
Sure. Well, hi everyone, and oh, there's the slides. Yeah. Hi everyone, and good morning. I'm John McElveen, and I serve as the State Opioid Treatment Authority for the state of Oregon, and obviously the OHA Health Systems Division. I think I know many of you from working over the years on various SUD and OED related topics, and kind of like on the same theme as what Lisa mentioned, and didn't really want to do a big deep dive into all the details of IET. I think everyone knows it's a established measure, one that's looked at by CMS and others in terms of measuring engagement in Medicaid populations for SUD treatment and the like. What I really wanted to do though was kind of, thank you, Lisa, really just talk about some key considerations kind of in thinking about the time and the short time we have together. Talk a little bit about some facts and trends, some of which you already know, I'm certain. And then kind of some key points going forward. When I think about the initiation and engagement measure, I kind of think about those things. I think everyone knows what, and Frank, I know, was going to speak to that, and hopefully we'll get a chance to hear from him a little bit about the details of the measure. But really what we're talking about is engaging people in SUD treatment, really in order to obviously address what's a chronic health condition, but also to hopefully alleviate or mitigate some of the other factors that many of these folks face. So let me just jump right into it. Oregon, as many of you know, is experiencing a historic rise in overdose and death rates. There are communities across Oregon right now where the overdose death rate is 3 to 4 times, if not higher, than it was at this same time in 2019. So it truly is, it's not hyperbole to suggest we really are in a crisis situation. And it looks much, much different than it did 8 years ago with what we remember as the prescription drug opioid crisis. Polysubstance use disorders are rapidly becoming the norm. I think those of you that have any experience or history or knowledge in working with or around SUD programs, I think many of you who have that probably have seen the progression from really focusing on a primary drug of abuse to focusing on the polysubstance issue, because it obviously impacts the patient in a variety of different ways and just really increases the acuity of even other co-occurring conditions, whether they be mental health or physical. And still many areas of the state still lack evidence-based treatment options. We, through federal grants and other initiatives, and some, and I'll talk about this in a little bit, some in partnerships with coordinated care organizations, we have increased access significantly, but there's still a long way to go. I think a good analogy is that, unfortunately, and I don't want this to be all doom and gloom, but unfortunately, the problem is outpacing even our ability to come up with solutions at this point, which kind of begs the need for more collaboration around this. What are the positives? Obviously, increased funding for SUD and related behavioral health services. We have significant increases in rates for our providers, which will allow them to keep a sustainable business model and provide these services. Some of our providers, and all of you know this, there are corners of Oregon where they are the only behavioral health and SUD provider. So that's a very good thing. But I think also when we talk about engaging folks in treatment for SUD, we want to look kind of back at the policy achievements. We talk a lot, and those of you that have heard me talk a lot about SUD being a chronic condition, treatable, not unlike hypertension, diabetes, asthma, or the like. And there's a research history of those comparisons being done quite appropriately, I believe. But there's been a lot of policy achievements. Hospital 27 state to kind of view this or put it in a lens with the other chronic conditions that many Oregonians face every day. But we have positives, the 1115 waiver that many of you obviously know about and have been involved in on some level, or at least have been in the listening sessions. Those things, as well as the other things I mentioned before, provide opportunities for alignment across the policy, payer, and patient landscape. So while in summary, while we have some serious challenges, we also have some tremendous opportunities, and they're tangible opportunities. And I think thinking about not just the future of the IET measure, but the future of just overall initiation and engagement of our population, of the covered lives population in SUD treatment is pretty achievable. And I think there's a lot of neat things we can do in coming years. So next slide. So the next slide, I want to just talk about, again, in the spirit of time, and just have a few more minutes left, but I kind of picked these talking points to highlight a few different things. Some of you have probably looked up the literature or the reviews. There's some peer-reviewed publications that have talked about the IET measure from a national level, CMS. And there are some things that kind of stand out, and that's the first point, are the characteristics, best practices and successful management of ablation. There's evidence to suggest that models, unfortunately, such as what Oregon has with our coordinated care organization system, with more local specific, geographically specific, for lack of a better word, management, has better results. Payers have noted that they've been able to, with the kind of, and I've seen this written before, the boots on the ground type approach, have been able to have better results when it comes to initiation and engagement of the covered lives population when they make relationships, and I mentioned that a little bit later, with their local community and their local treatment providers. And take an inventory. You know, and I guess I'll speak for myself, anecdotally, it's really from years of working in this system. What I found is that there are many folks on the CCO or payer side in general, and in general, it could be commercial insurance as well, who really aren't aware of what's available to folks in terms of access to treatment. I think, and I look back on different experiences I've had over the years in working in various roles at OHA, and I think about intersections with, for instance, the justice system, where many folks that have said, you know, oh, these folks need to go into residential treatment. That might not exactly be true. The best way, and I'll get to that in a few minutes, but the best way really to take a look and see what is in your community and what's to offer for patients who are experiencing SUD, regardless of the drug specifically, is to really get a better understanding of what's available. You know, really important. I just find it's a gap. It seems simplistic, but it's a gap. We still have, and going into the next point, we still have significant deficiencies in network capacity. As I mentioned on the previous slide, we have many areas of Oregon where folks are simply not able to, without traveling large geographic distances, access evidence-based services such as medication-assisted treatment, such as withdrawal management, which sometimes can be life-saving. That's not to say that we can create all parts of the network overnight, but it's worth being aware of and trying to look at what could be possible for deficiencies in services, or the vision of those services, I should say. Assessment and evaluation, I jumped a little ahead. Understanding the needs of the population, about the basics of how to assess them. For years ago, chemical dependency is really because you and your role may not be doing work specifically on the clinical role. Understand that. I think it's really important to being able to better. I mentioned I keep going where in the drug court system, there was always a desire to say for that. And and to say, what does the assessment say? Go back when I talked about policy and, you know, the declaration of SUD as a chronic condition. We want, if we're looking at it as a medical condition, we want to make sure that the evaluation assessment is aligned with the key concepts and how we treat other chronic conditions. It's an important step forward to everything from reducing stigma to just providing better services. Again, I can't tell you how many times I've met folks that really don't even know the treatment providers in their own community, long-term treatment providers. Getting to know them will help understand the process. And also when we talk about things like barriers, we're not going to get into a lot today, barriers to care coordination, some that can become real allies and real assets when it comes to helping to create a better system of care coordination. And it really is about relationship building. And I'll specifically, I'm not volunteering any of my colleagues, but you do have
Hey, John.
coordinated care. You have group matter experts that will assist with this. So, Lisa, do you have a question?
Hey, John. We're having an audio breakup.
Yes.
And we actually, I thought it was just me too, but it looks like it wasn't just me because I thought it was my internet. So we're actually going to have to probably move on. So your internet's just as bad as my internet. But thank you. It was good for
I'm sorry.
Your internet was breaking up towards the second slide, but we totally got you on the first slide. But now we'll see if Frank's internet is being kind. Frank, how's your internet working?
Can you hear me now?
Frank, we can hear you.
Okay. Yeah, I called it from my
Frank,
phone. Okay.
Can you go for about 5 minutes, and then we'll see if your internet holds out for 5, and then I'll go to Multnomah County, and then we'll go to Virginia Garcia. Thank you, John. And your internet was definitely playing a little funny, and thank you for those that were reaching out in the chat stream.
Okay. Hi, everyone. This is Frank Wu. I'm a research analyst with the Quality Metric Survey Evaluation Team in OHA. Let's go to the next slide, please. So yeah, since we're like 2 years late from holding this learning collaborative, I think most people probably somewhat familiar with the measure specs. And the basic is that if a member is 30 years and older, has a SUD episodes, they could be in the denominator. And there are some criteria for denominator logic that there is an intake period from November 15 of the prior year to November 14 of the year. And then there's a negative SUD history to make sure that new episode is new. And there are some larger changes starting 2022 is that in the past, a member can only have one new episode in a year. So they only will focus on one new episode. But starting 2022, a member can have multiple episodes. And also another interesting thing to point out is even though there's a 194 days for negative history, some of the visits are excluded from using to identify a negative history. For example, ED visit for SUD condition is not used in the negative, which means that if a member has a consecutive ED visits for SUD not being addressed, they can actually result in multiple denominator hits for the measure. And on the numerator side, the initiation can start on the same day when the first new episode happened through 13 days after. So it's total of 2 weeks, 14 days. And the engagement visit date is starting from the day after the initiation through 34 days. Next slide, please. So as I mentioned, there are some continuous enrollment criteria and also some denominator logic that make sure that the member's episode is new and the CCO has adequate time to provide care. And some other interesting changes include, for example, in the past, John mentioned earlier about the polysubstance use. In the past, the treatment has to have matching diagnosis with the denominator event. But starting from 2022, there are some matching requirements for the MAT medical assistant treatment, but for the visit-based treatment, they do not require the diagnosis code to be exactly matching. So any SUD-related treatment can count as a numerator hit. So I think that's actually a good thing. So kind of they don't force you to address every single issue identified in the denominator triggering event, but if you have some SUD treatment, it will count. And yeah, I think these slides are available, and we also have the specs published on the internet, so you can probably get to see more details over there. Next slide, please. So an important part is to mention that we also have the ASPER measure, which is kind of on the earlier stage to try to identify member with the issue, right, and then get referral and to get the treatment, and the IET measure is kind of like the part that following on experts some incidents that make sure that the member had treatment. So there's one also interesting aspect to that is that the initiation visit can be on the same day as when the person is diagnosed with a new episode, and also it is allowed for a member to have 2 engagement visits on the same day. But the tricky part is that the HEDIS specification actually require us to identify it has to be from different providers to count a same day initiation or like 2 engagement visits on the day. So this also just we think some of the CCOs and providers being trying to improve their data submission in claims to help OHA to identify different providers. Next slide, please. Start going into some of the results recently. So this is the most recent CMS core set chart pack from FFY, the Federal Fiscal Year 2020, which is actually calendar year 2019 results. And we can see Oregon here is just around the middle of the pack. You can just see the color theme, and there are some detailed numbers you can find out in the CMS, the report link below. So this is alcohol initiation. We're in the middle of the pack. And next slide, please. For alcohol engagement, we are actually on the first quartile, which is like the 25th percentile range. Next slide, please. And then this is the initiation for opioid. We are also middle of the pack, like the light blue-green color. Next slide, please. And for engagement of opioid, we're also around the middle of the pack. And next slide, please. So this is Oregon's overall results from 2020 measurement years result, and we have some breakout for age and also by cohort, and it's pretty clear that opioid get a little bit more attention, has higher initiation engagement rates, while alcohol and other drugs are lower. Next slide, please. Oh, so the last slide is the initiation rate, and this is the engagement rate, and similar pattern, but it's still you can see the overall engagement rates across it's about 15% and very higher for opioids. Next slide, please. So because of the spec changes, we have only have 2 years of data to look at right now. And this is the change from 2019 to 2020 for initiation of lab engagement on the right, and we can also see the household language on the left-hand side, on the bottom of the chart. And I feel it's actually really surprising that given the pandemic started in 2020, we actually didn't see huge decline in the rate per se. From 2019 to 2020, actually we see slightly increase in the improvement in the initiation rate in general. But you can see some of the household language groups actually saw huge decline, like initiation part from for the Vietnamese population and engagement side for like the Russian-speaking population. They really decreased a lot. Next slide, please. And this is also a new data set we're being trying to use to break out members by race ethnicity groups. And on the higher level of 9 categories here, we can see from 2019 to 2020. 2019 is the slightly lighter blue dot, and 2020 is the darker blue dot. And you can see on the initiation side, most language groups actually saw slight improvement. Not language, the race ethnicity groups saw some slight improvement. On the engagement side, the change also isn't very big, but you can see, for example, the Hispanic Latinos population has a more significant decline in the engagement rate. That's the data I'm hoping to share here. Back to you, Lisa.
Lisa, if you're talking, I can't hear you.
That's because I'm double muted. There's like, too many buttons to work with. Thank you, Frank. That's rich data. I'm going to transition. Let's see who our Multnomah County partners are on. Let's go next slide, please. And looks like they're going on camera. Kevin, thank you for being so patient. Let's see here. It looks like we have Kevin and Kristen. Would you mind introducing? And then Jennifer is happy to advance your slides. Let's go about maybe 10 minutes if we can, and then we'll transition over to our Virginia Garcia, and then we'll just open it up. We also will be continuing this conversation in our May conversation in the afternoon. So we might, Laura might be in follow-up conversations with you all as well. So Kevin and Kristen, thank you very much for joining.
Sounds good. Can everybody hear me? Somebody. Can anybody hear me?
Yes, we can.
Okay, yep. Good. It's that scary time in between that. All right, so my name is Kevin Miner. I'm a licensed clinical social worker. Preferred pronouns are he and him. I oversee the Integrated Behavioral Health and Addictions Manager position. So that just means that I oversee behavioral health and addictions within the primary care clinic and school-based health centers. I'm going to turn it over to the amazing Kristen Myers, who I could not do anything without her support.
Good morning. Can you guys hear me?
Yes.
Okay, thank you. Kristen Myers, Program Specialist with the Integrated Behavioral Health Team. Thanks for having us.
No problem. Next slide, please. So yes, we're going to be talking about the initiation, engagement, and substance use disorder metric. Next slide, please. So what we do at Multnomah County is we use the Collective platform to obtain our IET cohort data. Collective used to be called Care Everywhere. We do that because our EMR Epic is really not able to capture the data that we want. We have other data sources, but we felt Collective was the best choice given that it really gets the closest to real-time ED updates and other community providers that were in it. And we can pull that through a cohort that indicates a substance use diagnosis that fits within the time period of IET. So that's been super helpful. What happens on a weekly basis is we provide a list of individuals to each behavioral health provider based on their clinic, and is informed to them that they need to follow up within a certain amount of period of time, given when the SUD diagnosis was provided. This is weekly, so we may miss people, but we'll get into that, not miss people, but we may be caught flat-footed. with a week in between, and we'll kind of get that in a separate slide. And then we also want to make sure beyond just this list that our PCPs are aware of the IET metric, and when they either encounter an SUD diagnosis when scrubbing a chart, or they themselves provide an SUD diagnosis to the member. And in that case, it becomes an automatic referral to the BHP. Now, we also have 2 addiction specialists that we are absorbing that role because of we were able to craft it in a way that 42 CFR is no longer an issue for that role. And so they do get referrals to them as well. However, they cannot count towards the metric, given that they cannot document within our EHR and cannot do other things given their 42 CFR status. And they're currently contracted through CODA, which is a drug and alcohol treatment center throughout Portland and other areas. Next slide, please. Barriers. So again, restriction of provider types, that's what we talked about with the contracted CODA. Complications of COVID, right? So this caused just about anything and everything. Any time of metric that I report on, I just throw COVID in there because it messed everything up. The time frame struggle, 14 and 34 days turnarounds. That's difficult because our providers are sometimes booked out. BHP providers are sometimes booked out 3 to 4 weeks. We can do some kind of urgent follow-up calls, but if the individual is interested in engaging, then that obviously kind of pulls out the work that we have to do versus just calling them and have the individual decline. Really have not figured out automated tracking yet. Still have to do it via an Excel spreadsheet and still have to use Collective, which again kind of is time consuming, but also just kind of provides more and more barriers. The cold call is tough, right? For a lot of individuals that we call, they may have co-occurring other issues, mental health issues. And so when we call and say, hey, we've noticed that you went to this entity and were given this diagnosis, can bring up a lot of paranoia, can bring up a lot of where'd you get that information? Why do you have that information? There's also some concern, obviously, with individuals that we just call and say, hey, we've noticed that you've accessed the ED, 3 times in the past week for alcohol use disorder or drinking too much. And for a lot of individuals, especially that population, like, I don't want to talk to you. I don't want to talk about this over the phone. I don't know who you are. And that's a really sensitive subject. So that's probably one of the largest barriers in terms of engagement. Declining services, right? Same sort of things falls into that category. We're going to deny the problem. We're going to question, again, why the caller is knowing this information. How to manage out of care patients. So again, any individual that's connected to our clinic doesn't necessarily mean that they are have seen the PCP in a while, or is currently still seeing our clinic and maybe have switched over to another one. We're still going to capture those patients, but it is difficult to connect with them and then kind of have that first contact be, hey, it seems like you might have a drug and alcohol substance use issue. Do you want to talk about it? ED follow-up, not always connected to SUD. Patients are often seen by the PCP or ED follow-up, and PCPs do not review the SUD, right? So there's a protocol in place that if a patient accesses the ED, then the the PCP that has that patient on their panel has to follow up, and they don't always necessarily cover the SUD diagnosis if it's there. Knowing who's in the measure, I need to actually read ED visit notes and to see if they meet criteria, right? So like just because they've accessed the ED and maybe they have a substance use disorder on their diagnosis list doesn't necessarily mean they meet the criteria. So again, it's just that extra step versus sort of a more less complicated metric like an A1C over 9 diabetes metric that's pretty clear and easy to track. Next slide, please. So these are our 2021 outcome. So we had 561 eligible, 444 were not reached, and 117 were reached. So I know those numbers are like, whoa, that's a big difference. Would argue that 117 is still a lot of individuals that had an opportunity to choose if they wanted to, further explore their substance use disorder, which I know we can get higher than that, but I don't want to discount the fact that those are a lot. And then just real quick on the questions, thank you. Do you use a pre-built cohort report? Yes, we've requested a specific cohort report with our collective contacts. And so that's how they were able to create that. Next slide, please. So this is cool. Is again, 40 no outreach completed in timeline, 24 no working number, 85 never responded to outreach, 121 out of care for 1 year, and then 174 were never seen by Multnomah County Health Department. And so again, it captures a large population that we might not have interacted with, And so that's maybe something to think about in the future of how we can kind of stratify that data and maybe use a different workflow for the individuals that fall into this category. So Ed, yeah, so great question. It's on top of the FTE that is already with the BHPs, right? So, and then Kristen uses, I mean, she's gotten much better at it in terms of efficiency. She's always been good at it. She can get this out pretty quickly, but it still takes a lot of time. But no new staff were added or no new FTE was added to meet this metric. We just had to kind of absorb it and figure out how it could fit within our current job roles. Next.
Hello, this
slide,
is
please.
Jeannie.
Yeah. Hi, Jeannie.
I apologize. Hi, sorry for interrupting. When you, we just read the question in the chat for me because I'm following along on my slides, but I'm not able to get on Zoom today. So if there's a
100%.
question that comes through, would you mind reading out? Awesome. Thank you so much.
No problem. So just to go over the two questions that we did do, thank you for sharing your workflow. Is there a pre-built cohort report and collective to identify patients, or did you a custom build cohort to report this metric? And we used a custom build cohort. And then the second one, FTE needed to review reports and refer. No new FTE. So it just kind of falls into the current job role that everyone's already doing. ITE eligible, the cool stuff, right? 7 were in jail respite. 9 were already receiving care. 18 no-showed. 31 no-showed. And then 33 declined. So both 18 and 31. And then 18 met the metric. So of these 561s, 18 met the metric, which again, I would argue is pretty legit and cool, given that for a lot of these individuals, if that one contact, that window is so small for individuals that may be struggling with substance use disorder, if they are able to get some level of clarity, some connection to treatment, it really can save an individual's life, no matter what the population is. Why the two different no-shows? That may be an error in our data. Kristen, do you want to talk about that?
Yeah, sorry about that. It just didn't show up there. So for the 18 patients that no-showed, that means they didn't show the initiation visit. And then the 31 that no-showed, those patients didn't show one of the 2 engagement visits. I'm sorry that that didn't show up in there.
That makes sense. So for the people on the phone, the question was, why are there 2 no-showed? And it was just delineating between the 3 contacts that are needed for this metric. Next slide, please. Is that it? Right on. All right. So any questions, thoughts, or feelings regarding this? I know I talk really fast and we don't have a ton of time. Okay, I will end with this. This is an extremely important metric. You know, we're continuing to look at how we can, you know, figure out this complicated metric. I mean, it's a complicated metric because there's, you know, 3 contacts within a certain amount of time. This is a sensitive subject for a lot of people. And I'd say 42 CFR is probably our biggest issue in terms of following individuals. I would kind of end with, and this is my own personal, this doesn't represent the values and views of the Multnomah County, nor probably OHA, but if we are considering that addiction is a health issue and a medical issue, then I'm not fully understanding why we can't share that information within a medical setting, especially if it could greatly impact an individual's overall care. And so that's my 42 CFR kind of plug of that it should be reduced, because I really do believe it's very much impacting care coordination, as well as being able to connect individuals and communicate in a way that would better their care. All right, thank you so much for your time, and thank you OHA for asking us to present.
Thank you, Kevin and Kristen. And Kevin and Kristen, you will probably hear from us again. And Kevin, thank you for that candid and valuable information related to 42 CFR. And, you know, your title and integration. And I was at Clackamas County trying to lead integration, and I have my own personal opinions around 42 CFR, but then I have my own state, you know, role. And oh yeah, I feel you, man. So we should really have a personal 42 CFR conversation, and then we can have a real policy conversation around 42 CFR. But what I heard is collective has really served you some purpose. You've been able to figure out some workflow issues, you've richness of the data from your collective, and you did it all without adding some FTE, which is really just accolades there. My QI person in behavioral health, she just loved this metric from a monitoring perspective. And really not. But it's really profound work that we have to do for our members. So I'm now going to bring in Kimberly, and I'm going to say Allie, and Kimberly or Allie can possibly correct me. I know you don't have slides, but I wanted to open the floor for conversation related to lessons learned or barriers that you all have experienced on your side of the metro area related to this metric and population. So you have the floor.
Hi, everybody. I am Kimberly Wilcox, and I am the Director of Behavioral Health Services at Virginia Garcia Memorial Health Center. And Allie, would you like to introduce yourself?
Yes. Hi, everybody. My name is Allie Diamond. You said it correctly. And I am the Substance Use and Care Coordination Manager with Virginia Garcia Memorial Health Center.
And I do have our report that I could share if that is possible. So while I'm waiting to hear about that, I think that one of the main ways that at Virginia Garcia we started with this metric is that our data analytics department really started with this metric on, this is a really complicated metric. How do we track it? How do we know so that we can give the appropriate staff to respond to this metric the information that they need? And so that was quite the challenge. And let me see if I can share my screen here. Yes. So I'll share with you the report that we currently have, which is a really cool report that is a color-coded report that really communicates with staff. We do this report very similar to how Kevin talked about. They do a report. It is generated through a collective cohort, and it tells us patient name, patient MRN, and using this color coded whether or not we should be pursuing engagement or initiation, what clinic they're assigned to, what team they're assigned to. And then you will notice as the report goes on who their PCP is, the patient's date of birth and gender, what their index episode defined as, where did they get the, when did they get a new diagnosis? Where did that diagnosis come from? And you will notice one of the things that really surprised us is that the majority of the diagnoses were coming internally through Virginia Garcia with really limited follow-up. What that facility was, where they got that, and then what the provider, who the provider that gave them that diagnosis, and what diagnostic code did they use. So this goes out to, this report goes out to our, I can stop sharing. It goes out to all of our behavioral health care coordinators. Particularly, we have two different ways that they're dispersed. One is through some specialty programs like our population-based health, and others go through our MAT program. And we have behavioral health care coordinators that are that push out the report to the providers as well as the behavioral health clinicians, is how we utilize that report. And the color coordination in the report is really how much time do you have to respond? And so if it turns that sort of pinkish reddish color, it's too late. If it's green, it means go, and yellow means hurry up. You don't have much time left to respond. That report has been a huge game changer, where initially we were just sort of trying to keep our heads above water in both identification across all of our primary care sites. We have 5 primary care sites, and 5 school-based health centers and a women's clinic, which is a satellite office of our Hillsborough site. So this report really, really helped us. What we have struggled with due to COVID is really coming up with a specific workflow of what to do once we have this information. And I will say in the development of this report, the reason that it took such a long time is that we were getting extraneous data in the report and concerning data. One of the biggest things was when it was a 60-day mark, a new diagnosis within 60 days, that a lot of our engaged and stable MAT patients were showing up on the report if they did not have a UDS or had seen their provider for medication in a 60-day window as if they were receiving a new diagnosis. So I think some of the changes that we've seen for 2022 are going to make a huge difference for us. I want to say, Kevin, how much we appreciate what you said about 42 CFR. That has been really, really huge for us. And I agree that it doesn't make any sense in a medical model. And I want to hand it over to Allie to talk about some other challenges that we've had and how we have decided to really be able to drill down and focus on those challenges, hoping to address them so that we can better meet our measurements.
Yeah, so I know we are running short on time, so I will make it relatively quick. I just really wanted to echo actually a lot of the things that Kevin had said, because we are really experiencing a lot of the same challenges and barriers. One thing that I think would be super helpful in order to meet the metric, I really wish that CADCs and recovery mentors were able to count towards the measure. I think that would help a lot, just because our staff with those roles tend to have more availability than providers. Provider availability, especially in a short time frame, is challenging. Some of our providers are booked out, for a month, and so it makes it really hard to get people in quickly and in a specific time frame. So yeah, that's one of the major things. Basically, provider availability and our mentors and CADCs not counting towards the measure. Those are kind of the main challenges. And staffing related to COVID and whatnot. We don't have staff members who, that this is a new role for them. We have our staff members who have, existing, that have like existing jobs kind of working to meet the measure. So yeah, we really hear the issues that Multnomah County was having. And I feel like those are really a lot of the same things that we are also struggling with.
I think I would also add that when Kevin was talking about the difficulty in cold calls, that in our experience, those are received very differently by our patients when they get a cold call from a recovery mentor versus somebody with a title counselor or behavioral health in their title. And we've had way more success in that initial call to somebody being made by the recovery mentor. Kevin, I see your hand is raised.
Yeah, first a statement, then a question. First, I think John McLean brings up a huge point in the chat, so please read that. And in terms of 42 CFR, there is 100% a reason for that. There is 100% the idea that we want to make sure we protect individuals for a very sensitive issue. For a lot of people, can be sensitive in their profession. It can be sensitive to their family. I want to make that abundantly clear. What I'm indicating for the 42 CFR issue is just, can we reduce it in a way that would allow us to track the referrals a little bit better? Collective has a lot of individuals in it that aren't in it because they are a substance use treatment provider. So I want to try to figure out a way to do that. But I totally agree with John. I appreciate you bringing that up. My question is, how do you export the report in Collective? How do you get it out? Do you just do it via sort of switching it to an Excel spreadsheet, that information, or are you actually able to export it out?
So
we're currently exporting it into a Excel spreadsheet, and then the Excel spreadsheet goes out to staff.
Okay, and you manually doing that, or is it coming straight from Collective?
It's, as far as I know, it's coming straight from Collective, from our data department. So we don't even have to think about it. He creates the report and sends it out to everyone.
Thank you.
are there other questions folks have?
At this point, I think what we have decided to do, or I don't think, I know what we've decided to do is to really focus on this metric through our MAT department at all of our clinics, through our population-based healthcare, which focuses on our internally identified complex patients. So in each clinic, there is a hub of providers, social care navigators, and social workers that are working with these specifically identified patients at each of our clinics. And then we are also starting a pilot at our Cornelius clinic for all of our patients, so that we can create a workflow and identify what really works for us internally. So, and then be able to kind of work out all the kinks and then spread it across our system. Because we've had an MAT program for several years, when we are meeting the metric, oftentimes it is with patients who come into our MAT program, or were lost through our MAT program and are coming and end up coming back to us.
Hi, Kimberly and Allie. It is so rich of a conversation that we can keep continuing, which is just unfortunate. So I think, well, I know what I'm going to do. And I know I've already lost our Medicaid medical director. I'm probably going to have to loop back with Laura. I know we wanted to continue this conversation in May, and I already know, like, you know, I can see some people probably thinking like, okay, there's this thing already. There's a report that I know Kevin's using in Collective. Kevin already asked Kimberly, like, how are you getting this out? The point is, there's some things that we already know people are having some best practices, and how do we connect that information that you guys are already using, these tools and these workflows, so that those on this calls that are representing CCOs can then go work with their practices in their communities to be like, hey, I just learned that that Kimberly and Allie and John and Kristen got this information. You should go figure out how to drop it out in yours to connect. And then what we also heard is, when you're doing cold calls, having it come from those that are in the addictions world or in the behavioral health world, it's actually it's received better from the member and the patient. And then how do we create those systems of care in the clinics so that we can use our resources more effectively, i.e., you know, we have limited resources, so we don't have the luxury of adding more FTE. And how do we use those resources effectively to create those care coordinations? So I'm going to create some next steps of what are those workflows? What are those tools within Collective and pre-manage? What are some reports that are existing that was it a special report, which it was for John, for some, and is it a shareable report of, you know, like, who do I call? And then I'll create some of those tools with Laura, and then figure out how we package that up. And then we might create some of a more free form conversation in the May conversation to do another meeting just to have the Q&A part of this. So stay tuned, CCO quality folks, because that's probably what's going to happen in May. And we'll see if we can get some of the folks back into the May afternoon session. Maybe not all, but thank you, Multnomah County. Thank you, Virginia Garcia. And we might even get One Health from the Gorge to also come. They have some workflows as well. And the point is, again, to create those systems of care to meet the members. So I know we ran over. We'll have to continue to further the conversations in May on a whole host of things. Everyone have a good afternoon. If you are joining the QPI sessions related to statewide performance improvement project, please don't put us on hold, drop off and come back on. But otherwise, I'll see some of you at 1 o'clock. Please take a lunch break, do what you need to do, and I'll see you all shortly.
Thank you, Lisa.
You're welcome. Good afternoon. Laura Matola, are you on?
Can you hear me?
I can't hear you.
And I was only double muted. I did good.
I was double muted too. And then, you know, we'll see how long the good old hotspotting is working. So it's holding out. So far, so good.
Actually, you've been doing really good today. You haven't broke up or gibberish or anything. You've been very clear.
Hi, Lisa.
Hello. Well, you know, you just jinxed it, Laura. Yesterday was Sunday. Last Thursday, it was doing pretty well, and then it went south, so I had to like go off camera, but we'll see.
Dr. Back.
Who is anyone gonna turn their cameras on? I'm just gonna, now I'm just gonna start guilting people. This is the Quality Health Outcomes afternoon session. Hey, Tanvir, look at that. We get to see
Hi,
faces
Lisa.
if we're not in person at least. There's Laura.
Yeah, I was
Laura,
there.
you're in
I
an
just
office?
had the camera off.
That looks like an office. That looks like a legit office.
We're in a conference room. And Laura McKean's with me.
Hey, Miss Laura McKean, Oral Health Queen. Oh, that rhymes.
Cynthia?
I'm going to start rapping.
Sure.
No, I'm not. Hi, Erin.
We can't see. There's Cynthia.
Hi, Cynthia.
And Susan. And Susan.
And Susan. Oh, it's a party down in All Care. We'll just get going here in a second. Okay, so I am in California. We hope my hot spotting, but Laura Matola maybe just jinxed it, so we're going to hope hot spotting still holds up. We are going to cover a couple announcements, and then this afternoon session, we're going to cover the 1115 waiver integration statewide tip. Hi, Samuel. I'm just going to say hi to everyone that joins on camera. Everybody else, hello. But for those that specially join on camera, you get a shout out. Then we're going to cover the integration statewide PIP, specifically a couple of conversations. Maria Castro joined us. We'll talk about equity, especially around interventions. I will talk about the baseline data that you'll be getting. And then we'll be talking about external quality review validation, not specifically for the integration, but just validation in general, because you'll be validated for the SUD PIP as well. And then we'll spend the last hour talking about SUD PIP design phase. So that's today's next 2 hours. Laura, do you have any announcements or welcomes or howdy highs other than jinxing my hotspotting?
No announcements, but thank you for those who turned on your cameras. I appreciate it, along with Lisa.
Okay. Let's see here. So as a reminder, when you do speak, if you could, one, turn on your camera, but two, at least say your name and organization. So then we, again, know who you are representing. So that's just especially in a virtual world. It's really helpful to know who's talking. And then as a reminder for those that are, if you're not as familiar with Zoom, the reactions button, which is on the bottom of your menus, the little smiley face, if you hit that, you can see the raise hand function, or you can put any messages in the chat box. We are monitoring that as well. And then forever, as always, good reminder, please keep your line on mute if you're not speaking. If you've got your little animals running around, they might put you off mute. You've got little children around, whomever, whatever, just keep your line on mute unless you want to speak. Let's go ahead. Any announcements? Just general announcements related to quality. Number one, yes, OHA subject matter experts are reviewing your transformation quality strategies as we speak now. The OHA TQS leads checked in last week. We have not heard anything from our TQS SMEs, subject matter experts, about any delays, so I believe we're on target. We will be reaching out about those voluntary calls about feedback to you all, so those will still be offered with the agency. So what those are is, again, those individuals within a CCO. We usually work with the CCO's TQS leads, and then we work with someone on OHA side for working with scheduling for a voluntary feedback call if you want. So we'll work on identifying which CCOs want to do that. I think usually the timing usually have those written assessments out that June period, but we'll have that announcement in May. But we're on deck for we're on track for our regular review. We'll have an update in May. So thank you for those who submitted, and we'll continue to review. And that's the transformation quality strategies. The question around performance improvement projects, the CCO specific ones, your next submission dates for your quarterly progress reports are due April 30th. If you have any questions related to that, please email me. I know I'm at least dealing with one communication with Trillium, but if you have any direct questions, please do pop an email to me before April 30th. If you're wondering, like, hey, Lisa, what am I supposed to do again? Is that for all of them, including the statewide integration? Then drop that clarification. But your next quarterly CCO specific ones are due April 30th. TQS, PIPs. The SUD design 4th week of the month meetings, those appointment series have been sent out. So Jennifer has kept track of who has said, Lisa, please invite me to the 4th week of the month. So we'll talk about the SUD design phase at this QHOC meeting, 2nd week of the month, and then a 4th week of the month meeting has been scheduled. So if you think you were on that invite and you don't have an appointment calendar on the 4th week of the month, then you need to email me as well, and we'll get you on that invite. That's all the announcements I have. Any questions or anything for the good of the order before we get into the presentation? Okie dokie, no hand raising. Let's go ahead and go to the next slide, please. Okay, so I'm happy to, I'm going to go ahead and go first, Maria, and then I'm going to pass it off to you. So for the statewide mental health access monitoring integration PIP, normally what we did in the past, so pre-pandemic, for the statewide PIP, we would give you data. So the data comes from the agency that's used for the statewide PIP, and then that's what's given to HSAG, Health Services Advisory Group, our external quality review organization. But we give it to you all, and that's the data that's used for performance measure for the validation part. We would normally give it to you all in the frequency of the CCO dashboards. But since the CCO dashboards transitioned to a quarterly, I think, I believe they all got switched up because, well, you all know more than I do right now. So we'll still give you the statewide PIP data monthly. We have your 2021 baseline data. I have it ready. Thank you to a gentleman named Jason Flapp, our analytics. So before you all dealt with someone named Ying Han. So Ying was who you, if you remember Ying, she was the analyst who did all that opioid, high dose opioid data. So Ying is not doing the mental health access data. This person is now Jason. So Jason is your analyst for mental health access. I will send you all this information by email. Jason has run the baseline data for mental health access monitoring for 2021. So Jason has given the data to Frank, who you all met for IET measure, and Frank will give it to you all through that portal that you get your dashboard. So however you all access your CCO dashboards is how you will get your statewide PIP data, because that's how we did it in the past. So because this has PHI and you have to, you know, have the right kind of access for PHI information. So the data will be released when I give Frank the okay. I said I will give Frank the okay after I announce it at this meeting. So we will release the baseline data today. Frank will upload those files to the portal that you receive your CCO data dashboards. I will probably release it. I believe you all used to get your CCO data dashboards like the 4th Wednesday of the month. I'll probably still just follow that same cadence unless you all have a different preference. So Jason will run the data. It will be a rolling 12-month, just like it used to be. Even though the CCO dashboards don't come out on that same schedule anymore, Jason will run the data. He'll do the rolling 12-month. He'll give it to Frank, and Frank will put it up, and then an email will come up and say your CCO statewide PIP data is up on your is wherever you guys get your data, however you get it. Is that hopefully makes sense to whoever has access to those portals? Can someone give me a head nod or a yes, Lisa, I know how to get that data because that's how we've always done it. Laura, does that make sense? Roger that. Thank you, David Elliott. I love you.
It makes sense. I just have to check with the people who have access to the portal to make sure we can get it.
See, Laura, you're like me. Like, we know there's a portal. We know people, it's a limited access because it's PHI, and it's going to be the 4th Wednesday of the month normally. I will release it today. I'll send an email out with all of this. It's going to be a full calendar year baseline 2021. We had to wait for claims leg, and we had to wait for quality assurance check. So that's all done. That will get out when Frank loads it. There will be a nice email that says it's all done from me, and then it will have Jason's information that says, here's the analyst if you have questions on it. The other resource that's also available related to data is if in fact you want to measure, so sometimes, you know, the specifications are out there on the statewide PIP website. If you want to measure this in-house because you have your own claims data and you want to measure it a little bit more real time, but you want to measure it to the way that OHA is measuring it, you know, just to make sure you guys run it the same way, then you analyst to analyst can talk, you know. So sometimes I can't remember, I think IHN did it, I know for sure. They called up Ying and we just connected analyst to analyst. Then Jason's happy to talk to whoever is your analyst in-house, and they can talk to make sure you run it in-house the same. So that still is an offer if you wanted to have more real-time data within your CCO systems. So I will put that in the email as well. And Tanvir or whoever asked what's the name of the site, the answer is I'm absolutely of no help to that. I know there's a site and I know it's secure with PHI. It could be called SharePoint because we have SharePoint, but I just don't know. I don't know. Maybe someone else can help me out here if there's someone from analytics on the line and they can put it in the chat stream. So, and yes, you'll have CCO member level data And yes, it will be very specific to your CCO data. And yes, I'll share the baseline data with HSAG directly, and they'll have CCO rate data and the roll up for statewide, but they won't have member level data. Any questions? And maybe David Elliott, who knows that he can get to the data, maybe he knows it's SharePoint, but I have no idea. So that's the whole data question. Yes, you have. Yes, we ran it. Yes, we have it. Yes, you'll get it. Yes, you'll get it monthly. Yes, it has a member level. And yes, we will be a resource if you want to measure it in-house. And yes, I'll share it directly to HSAG, but they'll get the roll-up rates and the CCO rates, but not member. Okay, then I'm going to transition it to Maria. So in light of what we have, and you have probably heard it more than a few settings, OHA has a strategic goal around eliminating health inequities by 2030. And so everything we are doing across this agency and everything we're trying to implement has that framing. And that includes performance improvement projects. And so when we were looking through where can we implement equity in our work, but here's the thing, we have equity and we have performance improvement projects, and then we have this thing called CMS. And we have these accountability structures of CMS and protocols that maybe just haven't come to be the way that Oregon wants to be. So we have these accountability structures of CMS that we're beholden to, but then we have the future of where Oregon wants to move. And you know, they don't always line up. So we work with HSAG and we work with our lovely Maria, and we said, here's where we can move equity within performance improvement projects and protocols and the external quality review validation. And so we're going to have Maria speak to equity work in performance improvement projects, and then our lovely Christine with HSAG will speak to the validation, and then we will highlight where within the external quality review validation protocol, you know, the actual CMS, you know, where you guys actually submit your stuff, and what step you put in the bodies of work related to equity, or how you should approach the bodies of work with equity, and where you put that in the actual PIP protocol. So Maria will give the purpose and why and how, and then where it goes in the protocol is, you know, Miss Christine Hartman. So Maria, you have the floor.
Thank you, Lisa. Can you see me and hear me? Thank you. We had a little more than a foot of snow here in Hood River County, so I guess everything is out. There's no power, there's no internet. So I think I'm one of the few that has both. So until that changes, I'm gonna do this pretty fast. I have limited amount of time, but I think I can get the message across, and I think Lisa did a wonderful job grounding this work. With everything that we are doing at OHA, our work is equity center. We have the strategic goal of eliminating health inequities by 2030, and CCOs and pretty much every project has an important role on helping us reach that goal. And in addition to that, we have our health equity definition that, if some of you might not be familiar with it, I have it on the next slide. But both of them are the drivers of where the state wants to go. We are centering our work in equity. The work is equity, in other words. I want to call attention to two items in the definition that I think are very meaningful and will be able to assist you in this work, which is the last two lines of the definition, that achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address, number one, the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. So I know you're probably wondering, and how is that supposed to have anything to do with this work at hand? So next slide. So when you are asked in one section, the presentation of HC, oh my gosh, I forgot the acronym, HSAG, and you are gonna be, shown a slide about improvement strategies. I am asking you to, tackle this from an equity perspective. So in the you are gonna, be guided on, the quality improvement narrative, the barriers and the interventions, and in the interventions and evaluations and the process and the results. So when you are doing this work, I feel like the best way to sort of illustrate what does it mean, how is it that you do this type of work, centered in equity, is to use some questions that I don't want to call it a lens, because a lens implies that you have the liberty of taking the lens off wherever you don't want to use it. So I think that we could use these questions as an equity framework. So there are some questions that I think will be helpful to ground this work in equity. And they're very general, and I'm only using this as a suggestion. But I did add at the end of this presentation a little research that might help your work. So the questions are very, very simple. So are the communities most affected by health inequities and impacted by this issue your project is looking to improve? So are you actually considering those communities impacted by health inequities? And the question is, what does your quantitative and qualitative data tells you? Quantitative, I understand we do have limitations, but qualitative data, we have plenty. What are the barriers and the root causes for those barriers? How will you integrate the communities experiencing inequities on this work? Will the interventions that you develop will be done, including those that are most affected? Will your interventions be culturally and linguistically responsive? How will you know that you have succeeded from an equity perspective? And how will you know you didn't make it worse? So those are the questions that you and your teams can use to ground this work in this particular section of the PIP. And next slide. And while I do have very limited time, and I think like I'm already, done with my time, I wanted to provide you with this great resource. It's Racial Equity Toolkit to make equity operational. And it's was developed by the Government Alliance on Race and Equity. So my invitation is for you, all of you and your teams, to take a look at this toolkit and use this toolkit to ground the work that you're going to be doing with the PIPs. If you have any questions, me and my team are more than happy to be able to support your work and to guide your work and to be there for you if you were to need assistance. And I think that's it. That's all I have. Yes. Lisa, do you have any questions?
Oh, hang on. My computer's thinking. We're still here. Thank you, Maria. Before we go on to the validation part of it. So what I think Maria is really saying is, yes, equity is not a lens. We don't just stop doing equity and say, oh, I'm going to put those glasses down. I can't read right now. I only need those to look afar. I only need to look them close. We are always doing equity. When I say we, because I'm in this with you all, so when you're developing these interventions in your community and you're looking to say, okay, I'm trying to work through increasing mental health services for a particular county, I'm making it up, as you're developing that work, because you're looking, first off, you looked at your data that I'm going to give you, or you're looking at your own data because you already ran it, and you're just using my data to validate your data. And you're saying, okay, Lisa, my data shows me, and I'm looking at the root causes, and my data shows me that it's really this particular community, this particular region that is got some gaps, or it's this particular age population. And I'm going to look at the disparities. And I'm going to look within that, the interventions that I want to develop. Then what Maria is asking you is, maybe go to this GARE thing and start to look in the GARE thing to support some of those interventions that you want to implement. Number one, use the resource. Then number two, develop within those resources the equity framework that you want to develop in developing those interventions. That's what we're asking of you to do. And then when Miss Chris Hartman gets on this call, she's going to tell you, hey, this is where you note all that wonderful work that you did, i.e. you used the GARE resource that Maria provided you. You read the OHA equity definition, which again is a resource. You might have had your own other resources, and you use those to inform your interventions, which is by the way, step 8, which is what Chris is going to tell you. There's good preview. And this is where you document that. That's what we're in essence telling you through the Maria conversation. So Lisa provides you the data, which will help inform your analysis, which helps inform this step. Maria told you to use an equity framework, which helps inform your constructs of step 8 of your intervention, which is what Chris will tie all together in your validation presentation shortly. This will all get knitted together when Chris speaks too. And Laura said she checked with her file retrieval people, and she says the dashboards go to SharePoint. So we have closed that loop as well. It's SharePoint, and yes, that's where the files will get loaded as soon as I tell Frank he's good to go to upload them. So look at that. We're just checking off some lists right now. Any questions for Maria? Maria, are you planning on staying for the Chris Hartman part of the presentation?
Yes, I am.
Okay, great. So you can always think of questions as we go, but we're going to transition to the next slide. Thank you, Jennifer. And Chris, again, Chris Hartman represents HSAG, and I believe HSAG has multiple people on, but Chris will be the primary presenter for the validation update. And then again, this is for specifically, or it's for all PITs, but for it's not, let me just be very clear, it's not for the CCO specific topic one. So this is for the SUD statewide and for the integration. So again, not for the CCO specific ones. Those are the quarterly progress report ones. Laura, your face looks confused. Did you have a question about that? Okay, I just wanted to make sure that y'all don't think we're validating, that you're submitting validation forms on all these others.
It was a comment in the room that confused me.
Well, I'm just going to say, Cynthia, stop confusing Laura. I'm not even blaming Cynthia. And let's go ahead and turn it. Hi. You're like,
to her. We're good.
It's like we're all back in HSB. Let's go ahead and turn it over to Chris Hartman.
Thanks, Lisa. This is Chris Hartman with HSAG. I just want to make sure you can hear me okay? Yes, okay, great. And I do apologize. My video camera is not cooperating with Zoom, so I apologize. I'm not on camera, but hopefully all of the important information is going to be on these slides. So you shouldn't miss my face too much. And thank you, Lisa and Maria. Just so everyone knows, as Lisa just said, my presentation will be covering the PIPs that will be validated for Oregon CCO's this year, which will be the 2 statewide PIPs, the mental health access monitoring PIP and the new SUD PIP. And so this presentation is going to take a little bit of a step back, and we're going to cover everything for PIP validation, but I will certainly touch on the health equity piece and where that will be documented in your PIP submissions, as Maria and Lisa mentioned. So really quickly, the objectives of my presentation will be, again, to just review requirements for PIPs and federal requirements. They are required by the CFRs, and review HSAG's PIP validation process and what we'll be doing this year for 2022 and what you'll be responsible for as CCOs submitting PIPs for validation, key dates, all those sorts of things. So we can go ahead and move forward to the next slide. Great, thanks. So again, just really quickly touching on PIP validation requirements. This slide gives you the exact federal CFR code where PIPs are covered, and essentially there are 4 components of PIPs that are required, and that includes objective measurement using performance indicators, carrying out interventions to improve performance in those indicators, evaluating the effectiveness of the interventions that you carry out, and then using evaluation results of those interventions to increase or sustain the improvement that you achieve through the project. So in terms of validation, we'll be evaluating the design and the methodology of the PIPs that you submit as the external quality review organization, and we will be verifying the reported findings in terms of checking data analyses and interpretations, and then also evaluating the overall validity and reliability of the PIP results and assigning a validation status as part of our scoring process. So go ahead and move forward. So when we talk about PIPs, we can think about these projects occurring in sort of 3 stages. The foundation of your project is the design stage, which I think most of you are fairly familiar with. That's the methodology, the design of your project that you establish up front. That's what you're working on right now for the new SUD PIP, and that's also the portion of the PIP that you submitted last year for the mental health access monitoring PIP. So that includes defining the topic, the aim statement, the eligible population, those objective indicators, and your data collection process. So that's all covered in the design. And again, for this year's validation, the design stage, which is steps 1 through 6 in the CMS protocol for PIP validation, that's the only stage you'll be submitting and documenting for the new SUD PIP. For the mental health access monitoring PIP, you will be covering both the design stage and the implementation stage. So implementation stage gets into collecting and reporting measurement results for those objective indicators. This you'll be reporting your baseline indicator results, which again is what Lisa touched on, and you're getting that data today, so that's exciting. And then you'll also be describing your causal barrier analyses and your improvement strategies, and that whole piece is where you'll pull in the health equity in terms of documenting documentation of the PIP. You'll be addressing health equity in your step 8 improvement strategies documentation. So neither of these PIPs will be getting into the outcome stage this year. That will come into play next year when you have remeasurement 1 or results from the first remeasurement for the mental health access monitoring PIP. So once you have a second year of annual measurement results, then you can start looking at whether or not any improvement was demonstrated. And so we'll get into, I'll give you a little preview on the outcome stage during this presentation, but you don't need to worry about it in terms of documentation and evaluation for this year. Go ahead and move forward. And again, I'm now going to dive into that implementation stage, because since I believe many of you are familiar with that design phase or that design stage, which we validated last year, and we actually validated the previous year for the acute opioid PIP as well. So I'd like to focus in on these steps of the PIP submission that are new for you all to be documenting. So we're going to start with the implementation stage, which also aligns with steps 7 and 8 in the CMS protocol. There's step 7 is where you're analyzing data and interpreting performance indicator results. And then step 8, again, as I mentioned, is the improvement strategies. And we'll kind of touch on each of these and give you a little more detail. I'm going to interrupt myself. I know later in this slide presentation, I will share with you resources for your PIP submissions. And those include the PIP submission form, the PIP completion instructions, and the validation tool we'll be using. Just so all of you know, those are all accessible through the statewide PIP webpage on OHA's website. And they have recently been updated, but that's going to be really helpful for you in terms of your reference materials and giving you detailed instructions and reminders. So if you're trying to scribble down everything I'm saying, no need, it's all in those documents. But for today's presentation, we will highlight some of those areas of those forms. The submission form, the completion instructions, and the validation tool all align with the CMS protocol, which is organized into 9 steps for validating a PIP. So when I refer to steps 7 and 8, I'm talking, you'll find step 7 in your submission form. You'll also find it in the completion instructions, and you'll find it in the validation tool, and the same for each consecutive step in the CMS protocol. So with that said, let's go ahead and move forward to a little more detail on step 7, your indicator results. I will also add that for the mental health access monitoring PIP, you do not need to start new. You should definitely pick up the submission form, your final submission that you submitted to HSAG last year when we validated the design for the mental health access integration statewide PIP. So you're just going to be adding to that document. You'll want to address any feedback that we provided in the final validation tool for you last year, and then you're going to be adding to it. So you will have essentially completed steps 1 through 6 last year. And again, unless there's any feedback we provided you for any corrections that should be made in those steps. But going on, then you'll be moving on to step 7, and this will be new. You'll be adding your baseline indicator results. And it's essentially just, there's a table to give those results. You'll put in the measurement period dates. The baseline measurement period is calendar year 2021. So you put the starting and ending dates of that measurement period for the baseline. And then you'll report your CCO level data that you receive from OHA, the numerator, denominator, and percentage for that performance indicator that was defined last year for the integration PIP. And then there is a place for statistical testing in the table, but it is grayed out for the baseline. There's nothing to compare it to, so you do not need to do statistical testing for this year's submission. However, you'll want to keep that in mind next year. Again, when you have results from the first remeasurement, you'll be doing statistical testing comparing the baseline to remeasurement 1 results. In addition to the data table, you'll also do a narrative interpretation of those indicator results. There is a place in the submission form. It comes exactly directly following the results table where you will write up a brief narrative interpretation. And in both the submission form and the completion instructions documents, we give you step-by-step detailed information on the required documentation. So I definitely encourage you to refer to that completion instructions document, especially when you're writing up the narrative interpretation, when you're getting into step 8. We try to be very transparent in terms of what documentation is required to address all of the evaluation elements for the validation there. So those are really the 2 key components of step 7 for this year's submission. And again, that's only for the integration PIP. And then we can go ahead and move forward to the next slide, and we'll talk about step 8, which is really, I think, what most people feel if you're working in quality improvement. This is the exciting part. when we get into step 8, you're looking at your improvement strategies. This is what are we going to do to make a difference, to show improvement, to drive improvement in that indicator, in that objective indicator, to make a difference in the lives of our members. And we've had multiple conversations with OHA, with Lisa. We've heard Maria share, the OHA vision in addressing health equity and eliminating inequities. And because this was an ongoing project, and due to the indicator that was currently defined and with data available, it really made the most sense to incorporate health equity into step 8. So this is where, you're really going to dig in, and you're actually going to be looking into those interventions. What can we do to make a change? What can we do to drive the improvement? So in terms of your PIP submission and your documentation, this slide sort of summarizes the 3 components of step 8. So that first part is your quality improvement narrative. And again, I'm going to refer you to that completion instructions document. It gives you the step-by-step what we're looking for in terms of the documentation. But in a nutshell, we want to hear about who's on your team, who are you involving in the project to inform the improvement strategies, and what processes and tools are you using to conduct root cause analyses, causal barrier analyses, to look at the indicator that you're trying to improve, and as Maria mentioned earlier, to look at inequities related to this indicator and how you can both move the overall indicator results forward in the desired direction and also address health equity. So the next component, in addition to giving us that little narrative about your team and your tools and processes, is the barriers and interventions table. Just to remind everyone, the way that barriers are defined for this submission, we're talking about barriers to improving mental health access monitoring indicator. So that's the perspective that we're taking there. So we're talking about, again, what are the root causes that are preventing your members from accessing mental health care when it's needed? So we'll be looking to see in that narrative, what were the QI tools and processes you used to identify those barriers? What were the tools and processes you used to prioritize those barriers? Because we always recommend, you may identify 20 barriers to improving for this project, but what is realistic for your team, for your organization? What do you have control over? That is where you're going to pull in the prioritization and really try to identify what are the barriers that we have the most leverage to address. What are the barriers that are having the greatest impact on mental health access and on health equity? And so again, we're not only looking for you to identify and report your barriers, but also to prioritize them. And that barriers and interventions table gives you a neat little format for you to provide your priority ranking for each barrier. And then it gives you a column to describe any interventions that you are planning or have already begun initiating to address the barriers that you've identified, those high priority barriers. So the intervention description, that is the column that we're looking to see that you're addressing the health equity piece and addressing the guidance that Maria brought up earlier. If you don't feel like that gives you enough space to to provide a full description of the intervention or to talk about the health equity piece and how that's being addressed by a particular intervention, feel free to put a little note in the table and have an attachment. So we never want to limit you, your documentation. You always have that opportunity to kind of add an addendum if you need to, but do try to make a note in the submission form itself so we know to look for the attachment for the additional information. And then the third component in step 8 is going to be the intervention evaluation table. Now, this table may or may not be complete for this year's submission. We understand that you're just getting your baseline data now. And so, you know, ideally, you've already begun doing some of that causal barrier analysis with whatever data you have, with whatever QI processes you've been able to initiate. But it's possible that you may still be continuing that at this phase. And so you may not have fully initiated interventions at this stage. And therefore, we ask you to complete step 8 to the point that your particular CCO and your PIP team has progressed. We certainly hope you're thinking about and at least planning those interventions. And as you're planning the interventions, you want to be planning the evaluation of each intervention. So that intervention evaluation table is going to allow you to describe for each intervention the evaluation process. And then once you have results, you're going to be able to report those results in that table. And for next year, when you're submitting remeasurement 1 results, we're going to expect that table to be completely documented. And we certainly recommend that you're evaluating each intervention as you go. Certainly, if you're able to carry out PDSA cycles or some other sort of concurrent evaluation, that's highly recommended. Rather than what you don't want to be waiting for like annual indicator results to know whether or not an intervention is working. You want to have the data at your fingertips so you can make sort of data-driven decisions, revisions, and have an agile improvement project, if you will, to achieve optimal impact out of your improvement strategies. So yeah, I think that covers a nutshell of step 8, sort of an overview there. And again, just to recap, so the health equity piece, we're going to be looking in that barriers and interventions table, looking at those intervention descriptions. And again, if you feel that you've got more to share about that, feel free to add the additional addendum. As Maria pointed out, I think, you know, you have to keep health equity at the top of your mind throughout, and that's throughout all of this entire process. But in terms of documentation and accountability, that it's that intervention description that I would really have you focus in on. Okay, let's go ahead and move forward to the next slide. Now I just want to try to quickly give you a preview of the outcome stage, which is step 9. That's the final step of the validation. Again, you will not be evaluated on step 9 this year, but due to the nature of PIP validation and you know, the fact that we kind of validate about 6 months after you complete a measurement period, it's always a good idea to be keeping these things in mind and give you the preview at this point. So for next year's validation for the mental health access monitoring PIP, we will be validating the PIPs on outcomes. In the most recent CMS protocol for PIP validation, CMS has sort of broadened for us guidance on the types of improvement that we are expected to evaluate for your projects. So we did work with OHA to sort of define some criteria for these second 2 bullet points here, the clinically significant improvement and programmatically significant improvement. So this slide summarizes the 3 types of improvement that your projects would be evaluated on next year. The very top bullet point, improvement in performance indicator rates. So that'll be looking at that objective indicator that you've defined last year in the design that you've just received, you're receiving today, your baseline results. So we'll be looking next year to see if there was objective improvement in those indicator results from baseline to remeasurement 1. And again, that's why you're expected to conduct the statistical testing on those results and report whether or not there was a statistically significant improvement in those results. We'll be validating that, and we will be evaluating you next year on whether or not that improvement was achieved. So that's pretty straightforward. And actually, if we just want to skip forward really quickly to the next slide, I actually broke it down here I think I already just said all of this, but I will, that sort of part number 3 is that, just so you're all aware, we use, kind of an industry standard for the cutoff for what we consider statistically significant improvement. So that is, at a 95% confidence level, if P is less than 0.05 and the indicator results went in the desired direction, with statistical results meeting that criteria, then we consider it statistically significant improvement. So just giving you that heads up so you're aware for next year. And if you do, again, that's a ways down the road, but if you have any questions about statistical testing, we can certainly set up one-on-one TA sessions to provide you with some resources and some technical assistance on conducting statistical testing for your indicator results next year. Let's go ahead and move forward to the other types of improvement. So again, in addition to just looking at that objective indicator, CMS is also interested in whether or not these PIPs are demonstrating any significant clinical or significant programmatic improvement. Now, CMS did not provide us with clean and clear definitions. There is a definition of one of the two, and now I'm blanking on which one it is. And those definitions are provided in our completion instructions document. So you are, again, encouraged to refer to that document when you're thinking through significant clinical and programmatic improvement. However, what this slide summarizes is essentially the rubric that we're going to use, the criteria that we're going to be using to evaluate significant clinical and programmatic improvement. The key, one of the key things to highlight here is that we see these types of improvement as being linked to individual interventions. So the interventions that you're describing in step 8 as part of your improvement strategies, you're going to be collecting data to evaluate the effectiveness of those interventions. Next year, when you submit your remeasurement 1 results, you'll have the opportunity to look at those evaluation results and determine if a particular intervention based on the evaluation results demonstrated clinical or programmatic improvement. And you will have there's a table at the very end of your submission form that is called the Clinical and Programmatic Improvement Table. And that is your opportunity to document the specific remeasurement period, the specific intervention that drove the clinical or programmatic improvement. You'll document your evaluation results, your data that supports your conclusion that significant clinical or significant programmatic improvement was achieved. And that's what we'll be using to validate that portion of your project next year. Let's go ahead and move on to the next slide. Okay, so again, I've been referring to these all along, but just so you have it on the slide, we'll cover in general HSAG's PIP validation process. So those 3 documents that I've been referring to, the submission form is the document that it's a living Word document. You used it last year to submit the design for your mental health access monitoring PIP. You will be updating that same document, that submission form, adding documentation for steps 7 and 8, addressing any feedback from last year's validation, and that'll be what you submit. The completion instructions document is exactly like the submission form. It follows exactly the same format, except it has additional guidance, additional detail about documentation requirements, and also identifies links documentation to specific evaluation elements in our validation tool. The third document is the validation tool itself. That is what HSAG completes. On our review, we will score each evaluation element in alignment with the CMS protocol. We will provide our scores in that validation tool. We will also provide our feedback to you as comments in the validation tool. All 3 of those documents are available to you up on the OHA statewide PIP site. So you'll have those as references. And it also aligns with those 3 stages of the stage one, the design of your project, the implementation, and the outcomes, which will come into play next year. So let's go ahead and move forward to the next slide. One more time. So for this year's submission, for the statewide integration PIP, it will be steps 1 through 8 in the submission form is what should be completed. And for the new SUD PIP, you will only be completing steps 1 through 6, which is just that design piece. Go ahead and move forward to the next slide. And when you do get a chance to take a look at that validation tool, again, I would recommend going to the OHA statewide PIP website. We have recently provided OHA with updated documents there. There's minimal changes, but there is a change from last year. So you'll notice that the total number of evaluation elements increased from 30 to 31. And the critical evaluation elements have stayed at 12. But you will find the most recent validation tool on that website. It is available today. And again, this is all following the CMS protocol. So if you do want to access the CMS protocol directly, we can certainly provide you with that link. And you'll see that it follows the same 9 steps. And I do want to touch on critical evaluation elements just so everyone is that's refreshed in your memory. So the 31 evaluation elements cover the 9 steps in the protocol. HSAG has designated some of those evaluation elements as pivotal to the PIP process that drive valid and reliable results. And therefore, we designate 12 of those evaluation elements as critical. What that means, practically speaking, is that the score you receive on those 12 evaluation elements will drive the overall validation status of your PIP. That's the overall score that we provide with, to OHA and to you at the end of each year's validation cycle that identifies the PIP as either being met, partially met, or not met. And I think it'll become more clear if we move forward to the next slide, and we'll have that, that scoring framework put up there. So each evaluation element will be scored either met, partially met, or not met, as long as it's applicable. In some cases, we will score an element not applicable. If you're not using sampling for your project, step 4 is not applicable. Another exception is if the step is not assessed. In this case, neither integration or SUD PIP will be evaluated on that step 9, on that outcomes. That will not happen this year. And therefore, step 9 will be marked as not assessed. So any of those not applicable or not assessed evaluation elements are not pulled into your score, of course. Anything else that is applicable is scored. Each individual evaluation element is assigned a score of met, partially met, or not met. And then if we go ahead and move forward to the next slide, you can see that we'll take all of those individual evaluation element scores, calculate the percentage, that plus what the scores were of all of the applicable critical evaluation elements will determine the overall validation status for the project as either met, partially met, or not met. And that allows us to report to both OHA and other key stakeholders, to the individual CCOs, whether HSAG determined high confidence or confidence in the PIP results, low confidence, or no confidence. And you can see on the slide how those are aligned with the overall validation status. So let's go ahead and move forward to the next slide. Now that's a lot of information. Let's get into some more practical information about when all of these activities are going to be due and when we'll be reviewing and providing feedback, so we can move forward to the 2022 activities and dates. So I've got 2 slides. This first slide is specific to the integration PIP and that validation timeline. So you can see that the PIP submissions are due to OHA July 31st of 2022. And again, that's so basically from now until then, you have the opportunity to update your PIP submission form, completing all of the documentation for steps 1 through 8. We'll review those submissions in August, and then we will return initial validation scores and feedback to you and to OHA on September 9th. And then, as you probably recall, if you've been through this before, you have the opportunity to receive technical assistance. You just would reach out to HSAG. You'll have my email at the end of this presentation. You can email me directly and request a technical assistance session if you have questions about any of our feedback or would like further assistance on how to address the feedback. So we've got some time in September for that to occur, and then you have the opportunity to resubmit your PIP on September 30th. We will review and do our final validation in October, and we will return the final validation results on October 26th. So that's for the integration PIP, and if we want to move forward to the next slide, we can look at the dates for the SUD PIP. As you know, you guys are currently working on that design together collaboratively with OHA. You will be submitting the design for the SUD PIP on August 31st, of this year. And so you'll have it'll be about a month later that you'll be submitting that after the integration PIP. We'll do the same process, have our initial review, provide our initial feedback on September 30th. There'll be the opportunity for technical assistance, and then the resubmission date will be October 21st, and we'll do our final results delivered on November 16th. Slide, please. Just really quickly, we've touched on a lot of these throughout the presentation, but to sum it up, tips for successful submissions. Please submit your PIPs directly to OHA through the deliverables submission process that you've used in the past. You do have an opportunity to seek technical assistance. There's that built-in window during the validation process when you can seek technical assistance. You can also reach out prior to your initial submission if you have questions or concerns as you're working through your initial documentation. You can send an email and set up a TA call ahead of time if you'd like. And I've mentioned the references. They're available on that OHA statewide PIP webpage. And I think that covers it. If we want to move forward to the next slide for questions. And I think we're basically at the time allotted, and I didn't see any questions on the chat. I'll just turn it back over to Lisa unless there's anything.
Yeah, I'm not seeing any questions either. Anybody want to put something in the chat or raise their hand? You all have the slide deck, and obviously everything is posted to the QHOC meeting as well, or QHOC website for the slide deck. And then, like Chris mentioned, the actual PIP form, PIP instructions, and all the information is posted to the statewide PIP website. So you can get all that information on the PIP website, and then the actual slide decks themselves are attached to the QHOC website. Well, Chris, it was clear. So, if questions come in, there's Chris's email. You also have my information as well for anyone on the line, and I will literally just hit forward and get it over to HSAG. And we will move on to the next topic unless there's anything else. Not for me. Thank you, Lisa. Sounds great. Great. Thank you. Okay, we are nearing the home stretch. I'm going to keep my camera off in the interest of internet bandwidth. Apparently, more people decide to use the internet in the afternoon here in California. Let's talk. So I will first do kind of a summary of what has happened since the last QHOC related to the SUD topic, and then we'll kind of open up for discussion. So, only been a month, but a lot has happened. So, just as a reminder, we are trying to chart our course towards an SUD statewide topic. We are in the design phase. We have until August 31st. August 31st is the validation submission for CCOs. We need to obviously land on a topic, a population, and a measure. All the same things like we do every time. We need that measure to be viable across all CCOs. And when we say viable, it needs to be a measure that has a population size for all CCOs. It has to be in a measure that a population and a project that will move towards one of the SUD waiver goals. And in the March QHOC, we talked about the loveliness of 42 CFR. We talked about some of the waiver goals around treatment, and we talked about access, and we talked about workforce. That's just very broad, I know. We also have held internal meetings. So again, like we designed the mental health access integration PIP, we have two groups running parallel meeting structures. We have internal group of OHA subject matter experts, and then we have the external group, which is you all CCOs across the staff, so behavioral health and physical health and quality, whomever wants to come. So we've held, since the QHOC March meeting, we've held 2 internal groups and an additional external group. So from those groups, I'm going to bring to the summary of what I heard at those meetings. And let me do a quick check whether Sarah Adelhart is on the line. Sarah, have you joined this afternoon? Oh, there she is. Hi, Sarah. For those that don't know, Sarah is the policy analyst for the SUD waiver and one of the trustee partners who's helping lead this SUD PIP design work. So I just wanted to make sure Sarah's on the line because she also was who helped facilitate the last 2 sessions that I was able to miss. But I'll summarize where we are at for those topics from those discussions. So, like I said, we talked about workforce, we talked treatment, we talked 42 CFR, we talked, those are what we talked about last QHOC. What we've talked about at the last 3 meetings, internal and external, I heard we talked initiation, engagement, and treatment. We talked, get the notes, we've talked population-based, specifically in some of the populations. We've talked homelessness or houselessness. We talked pregnant women and broader postpartum / pregnant women and OUD and alcohol and other drugs. We talked for treatment, we've talked corrections, and we've talked what was the other treatment? Can't remember right at the moment. So we talked treatment, we talked like I said, population, houselessness / correction / pregnant women / postpartum. And then for kind of measurement, we talked IET, initiation, engagement, and treatment, and we also talked SUD access measure. So those are kind of what's been floating to the top from some of the last few meetings. What I wanted to open the floor before I ask just kind of random question. I'll just open the floor now to what are people's thoughts from the summary I just provided of what floated to the top of the last, which was populations of corrections, houselessness, pregnant women / postpartum women and OUD, alcohol and other drugs. That's the populations. From a treatment side, it was, someone did mention MAT, someone also mentioned corrections. And then The other areas were SUD access, and then the workforce has come up, but I'm not sure that we can measure workforce again. Not again. We've had that conversation around workforce, and I don't know if we have the data sources around workforce. So what are people's thoughts around those kind of broad categories, and somewhat specific if we speak around IET? And you can raise your hand or go on camera or put it in the chat. Oh, the question, Deanne, is just what are people's thoughts? Oak and Kat Livingston wrote naloxone. So the questions to David, and there are some broad categories, and I'm trying to narrow us, and or Lisa can, it could be the kingdom of Lisa. I've decided I'm just going to make my own kingdom. We can go in the population space, which is pregnant women or postpartum women and OUD and alcohol and other drugs, or population space of houselessness or corrections and OUD. We can explore those 3 different population spaces and have a deeper dive of conversation of, is this a viable PIP area that we want to talk about? Or we can talk in the space of access, SUD access. There's apparently an SUD access major that we currently report. And is that a space that we are interested in collaboratively working in? Or there's the space around treatment. One area of treatment that has been raised in the conversation was medication-assisted treatment. I'm not sure if that's an area that is consistently majority of conversation where there's interest to speak in that space. So we can, is there any one of those spaces that people have an interest in carrying forward a more deeper conversation so that we can get to a topic area? Population-based, pregnant women, corrections, houselessness, or access, which would be SUD access, broadly speaking, which is very similar to mental health access, or treatment, which at this point, the one that's been raised is MAT or IET. Canveer says postpartum population because of stigma. Just he's putting that out there. Dana Peterson, thank you very much for putting in the reminder of the overall goals of the SUD waiver. She just put those in the chat. So we need to figure out collaboratively between agency and CCO, where is the space we want to go into and into a PIP topic, and it has to be measurable. And so workforce is not that space because that's not necessarily a topic that's measurable, because we've explored that a year ago and it hasn't improved enough in a year to be able to measure that. So unfortunately, I'm making the call that workforce is not a space that we can go in a PIP area. I'm not saying that it's not important. I'm not saying that there's not policy areas. But as far as a PIP that needs to be validated, it's not a space that I can do. We had an interesting discussion around access in behavioral work in the last meeting. Right, kind of hard to measure. Exactly, David. I'm not saying that's not important, but from a policy place, we could totally do it or have a conversation. But from a PIP measurement and a validation, and you just heard Chris Hartman about the whole PIP measure and validation, it's not a space that we can do on the improvement side because of the constricting of the CMS protocol. So pretty much taken workforce off the table for the PIP lever that we have of quality. So we've got, there is a current SUD access measure, but that's very similar to mental health access that we're doing. Now, I'm not saying that it's, you know, identical, but we already are doing some monitoring around access, which hopefully is improving access care coordination services around in your communities. Do we want to be in the space of access for SUD? That's a question to you all. Or do we want to go in a more population health space or treatment space for the SUD waiver? That's my question to you all. Access, population, treatment. Given that this is the first year, would seem wise to look at foundational elements such as access. Having similar measures for both mental health and SUD would seem like a good integrated approach. Thank you, Dan. Just keep in the comments, or excuse me. You can go off mic if you like. Want to just, you know, open up the little dialogue.
Lisa, Anna has her hand up.
Oh, good, because my computer is going even more wonky and I can't see my screen. Anna, please.
Hi, this is Anna. I was just putting in the chat that I wonder if some of the populations might either be very difficult to identify systematically, such as the case of the populations who might be houseless, which would make it difficult to measure in a PIP kind of a setting, comparing apples to apples across all CCOs. And also, some of the populations may also result in some very small numbers for CCOs as well, denominator wise, which also makes it a challenge as a statewide PIP topic.
So Samuel just posted, I also worry about population specific just based on the limited number of members in our coverage counties.
Okay. Very good call, Anna and Samuel. When I was thinking, I'm for houselessness, that could be definitely an issue as far as how to measure that one, because I'm not sure how. Well, I don't even know if we can measure that in the claims. It's my guess his answer is no. But for the pregnant women one, the issue around population size, so Anna, would you have more than 3 people basically, right? We talked about how in certain smaller CCOs, having under double-digit populations for some of these topics is a concern. I've mentioned that before. And I have someone in analytics looking into that for a potential, since this was raised internal. I've had some just preliminary numbers being run to see if in fact, for smaller CCOs, if in fact pregnant women with OUD or postpartum, if it is even a viable population. So FYI, I have someone doing homework. Me and homework. I assigned somebody homework to see a small denominator population. Huh? What was that, Anna?
Oh, I was saying thank you. I appreciate that. You anticipated.
Yeah, no. So for some of the population measures that have kind of been thought of, I have someone doing some preliminary homework already, just to see if that's the case. The houselessness one, I didn't assign. I don't know if I signed homework on that one. I think I signed homework to public health to see if there's data to even think through what data is accessible. That's, I think, how far I got on that one. And then I think someone said someone's hands raised. Is Tanvir's hand raised? Did I see that?
Yes, it is.
Yeah,
okay,
hi.
Thank you, Tanvir.
Yeah, so I just wanted to bring up why I suggested the pregnant moms. The data points could be smaller, and so if we look at all of this from a system level, I am tying that in directly with the system approach that we're taking with the kindergarten readiness metric for 0 to 5, because just not only this particular segment of moms who have or suffer from SUD, but moms in general, pregnancy, you know, in many cases becomes difficult, but with SUD it carries a lot of stigma. And then expecting that they will complete the ages and stages questionnaire for the kindergarten readiness metric is going to be a pretty uphill task. So it's not going to be just working on SUD. You have the opportunity at CCOs to work on a system level approach, many education aspects. I just gave you one example, the ages and stages questionnaire, which ties in directly with another metric you already are working on. And it's also, both of these then become health equity. The kindergarten readiness is a health equity metric. So that's why I brought that up, so view it from a system level, not from the denominator or the N point of view. That's just my suggestion.
Thanks, Tanvir. Hang on, I'm just reading the chat. Aaron says, I agree with Dan. An integrated approach between mental health and SUDS would be beneficial as it lifts all behavioral health onto the same playing field. So what was brought to my attention was, and Dana, it sounds like you're on, Dana Peterson, our another SUD policy analyst within Health Systems Division, OHA. Was brought to my attention that there is an SUD access measure that is currently reported. I don't know if it's reported at the CCO level, which was another homework assignment I divvied out last week as well. So that is something, if you can check in with Geraldine for me on, these are all things that we need to check from a measurement perspective. We already have identified some of the problem areas of our system, and we can definitely figure out some of the root causes of those problems, but we do know that at least there's a measure that's already developed, but whether it's at the CCO level, that's the question. So Dana or Sarah, if you can put that piece of homework that was handed out last Thursday, if you could follow up with a little asterisk to that homework, or a little, addendum to the homework, to check to see if it's reportable at the CCO level. That would be another question, and you can say that it came from the QHOC discussion as well. Okay, so these are all kind of where the conversation has evolved since the last meeting. So we've got some synergy potentially from this access conversation, where your access work is happening in your communities as well with the integration work. Where if we go from a population-based approach, understanding potentially houselessness is not a population that may be viable not from a need perspective, because there's probably definitely a need. I just remembered one of the other populations that were reported as a need. And I'm going to put this out there, and we'll see what y'all are thinking about this, whether this might be an issue from a data perspective, but I'll put it out there. One of the populations and the needs that were identified was those that use illicit drugs. How do I say it? They said it was basically it's the other stimulants, the fentanyl, the laced drugs that are causing the most harm. So the work that we did several years ago in the high dose prescribing of opioids, so the prescription opioids and the high dose work, that's not the ones that are causing the greatest harm right now and overdose deaths. It's the methamphetamines and the illicit drugs of fentanyl laced drugs, or fentanyl like laced drugs. And those are the populations from a public health and SUD perspective that from a policy standpoint across the agency that was raised. What are people's thoughts in that? Now, again, whether we can identify the population, whether we can do it at the CCO level, haven't answered that. But what are people's thoughts about that population and the work you could do in your communities?
This is Deanne with
Are you
YCCO.
Yeah, Deanne.
Yeah, you know, I think that maybe the silence speaks for itself, but I think there's so many, with the SUD right now, there's so many different attentions, you know, as far as metrics, as far as the, you know, 1115, all of those sorts of things. So I think it feels like it's spinning a little bit. So I would just reflect that maybe that's kind of where some of our heads are at, is, you know, which part of the elephant do we bite first?
Yeah, I think there's no shortage of the elephant. There's probably multiple elephants too, unfortunately. And when we were talking about this space, I was also trying to, when I was speaking internally, I was also trying to think with my CCO hat on, because this is a Medicaid performance improvement project. But again, we try and do synergy across our policy work across the agency. But I have to think, what is it that you all can do as CCOs, you know, with your contract requirements, with your contracts with your providers, with your influence in your community, all those things. So I'm like, as a Medicaid plan, what is it that you can do? And so what is it you can do for your Medicaid members? What is it you can do for the community? So I have to continue to have that conversation internally as well. So I have to, can you bring, you know, the police force and the public health and all the other parts and entities to the table? That's part of the conversation as well, that I challenge my internal folks too. Let's read some of those. CCOs have an annual delivery. Yes, that takes place. Yes to all those points, Dana. And we looked into that a little more last year and currently, and it's still not in a place to use for a performance improvement project data source for workforce. So unfortunately, DSN is not a data source for workforce for a PIP. Not yet. Still, would love it to be, but not yet. And I'm sure whether the CCOs want it to be or not, it's still just not a place there. So that's why I've taken workforce off the table, because I don't have a data source that can be validated enough from a data perspective. Anna Warner, you wrote, focus on the IT measure would align efforts with those quality improvement interventions. Now, I was not part of the CCO's conversation around that. I know it was brought up. Does someone want to speak to the floor, since now I'm here and here's your time to, someone can say their piece around that, or more than one person. So I hear what your perspective is on this, so I can take it internally as well.
Hi, this is Anna. I guess I didn't realize it was part of a CCO discussion earlier. I might have missed that, but
it came up. I don't know what said.
I just, in looking at the, you know, the 4 points here from the SUD waiver, it aligns very well with point number 1. And assist Oregon in increasing identification, initiation, and engagement of Medicaid beneficiaries diagnosed with SUD.
Okay, so does anyone have thoughts? All I know is it was brought up at a previous meeting. I wasn't at it because I had a doctor's appointment last minute. So what are people's thought about IET? Now, I will state that we have not had our incentive measures and statewide PIP be the same. Just there has not been that. I, as a policy, have kept them separate. Not like it's a rule, it's not like a law or anything, guys. So what are people's thoughts in that manner of the IET space? I know it came up at it might have been the fourth week of the fourth week meeting, but I don't know what people's context or discussion around it was. Was it for alignment of efforts? Was it for, hey, just like Anna said, it lines Lisa with the goals and objectives that were just put forth on the waiver? Or is it that, because there's conversations also around, there's like a big elephant. We need to kind of work in a lot of different SUD spaces. So what are people's thoughts?
Well, this is Anna again. I guess I'll jump in with more thoughts. I think looking at I feel like the IET metric is a little bit of a bigger metric. It can be fairly broad, but it allows CCOs to tailor their interventions to the specific issues within their network that might be impeding members getting to their initial treatment or getting to their subsequent engagement, treatments in the metric language. Is it that there aren't enough providers? Is it that providers are booked out too far? Is it, integration between where members are identified and getting them connected to treatment? So is it the referral or a warm handoff process? I think there's a lot of different places where CCOs could focus work with a metric like that, and tailor those interventions to the specific issues being faced in the region. I think that lends it well to being a statewide measure for a PIP.
This is Deanne with YCCO. I would agree. I think that there's so much within the IET. I mean, it's big, don't get me wrong. It's an elephant in and of itself, but I think it does allow, to David's point, varying pain points. So each CCO could take within IET and determine what interventions will yield the best impact within that area, with an eye towards, sort of just improving on those two measures.
In the chat, we have crisis intervention and outreach is now an OHP covered benefit effective 1/1/22, which can help with identification and engagement. And it was from Dana. And then Ann Ford, there are some broader systematic issues that have to be addressed around IET. I'm not sure they fit in well within a PIP. For example, we need rule and documentation changes to make this successful. Lisa, are you still with us?
I am. I'm trying to click the right buttons as my computer decides to throw fits. Okay. So what I hear is there's some follow up with Anne to find out what kind of changes need to happen to IET. I also hear that there's some synergy that that is desired from the CCO perspective, whether it's IET or whether it's access. I'm just generally speaking. That there is some concern. Well, either way, we all heard that, you heard me and you've heard me continually say it. There has to be enough of the elephant for all CCOs in this PIP. Has to be measurable. And what we're looking for is, again, work in the SUD space for each community. And some of the population-based ones may or may not be measurable for some of those populations. So therefore, that would be very difficult. That was my general summary. Does anyone disagree with that so far?
I think you got it. The population ones, the one that kind of piqued my interest, but I keep thinking, how could you, I don't think we could get all the data points that we need or the information, but the one around corrections kind of was like, oh, it just gave me that little pause, like, huh.
Yeah, it's always the measurement part.
Yeah, that was the part that I was like, huh.
Well, here's the trick. The measurement part is around removing ourselves from the claims-based measure side of things, right? Our attachment to claims-based measure reporting. So, okay, so I'm gonna also think through, and anyone can, again, throw out others into the mix, but I have some homework. So there's IET, and can you, and you can maybe say no, I'll follow up with you, Lisa, later, but can you speak to what you think needs to be changed in IET for it not to be a good fit for a PIP?
Yeah, so in my opinion, I mean, there's some different ways that we can engage members that are not really supported well in rural right now, like the idea of a peer going out and doing a first encounter outside of a mental health assessment and a treatment plan, and being able to operate on that forever, however many sessions we all determine needs to be. And I know some of that is in process, but I just worry about, we really can't improve on the things that are set in administrative rule right now. That doesn't give us much room as a CCO or the CMHPs to be able to do anything really differently based on current administrative rule.
So if some of these things are in process, you're saying that you'd want to be able to do these interventions that are limited right now by certain rules, and you'd want, obviously, that to be fixed so that you could do those interventions.
Right, because right now, I mean, we've all talked about this a lot. The most effective way to engage folks is peers, and right now our model doesn't support peers being able to provide interventions up front of getting them involved in the system all the way, right? So we have to have an intake, we have to have a consent, we have to have an assessment, a treatment plan. All of those things require members to engage at a level that they may not be willing to engage at or able to engage at that moment. So, we can try to provide all the interventions we want, but if we don't have a system that's set up to support that, I'm not sure we're going to get very far. And that's more of a rules advisory process than it really is a PIP process.
Yeah. But that would be okay. So this doesn't have to be. This isn't an either or situation then, Anne. So I think. Oh no. But David, you're being funny. I don't hopefully have to go talk to the state attorney general's office. I think what she's speaking, well, and I don't know, I think what you're speaking to is there's certain services that you're hoping that a peer can deliver, and that a RAC would have to be convened, a rules advisory committee would have to be convened so that those services could be delivered by a peer, because it's best delivered by a peer. Now, I'm not saying whether they can or can't be delivered by a peer. I don't even know what services you're speaking to, because maybe that's a federal level and not a state level, but we have to look into that, right? And hopefully, again, I don't have to go to the state attorney's general office. Maybe David knows more than I do right now in this space, and he's like, yeah, Lisa has to go to the state attorney general's office. But I do recall there were certain services that were within, let's just say, our ability to change, and we just had to do some things. And when I say we, I mean whether it was the state versus, you know, our particular practice, the county, and whether we had to change who was the oversight billing provider versus who was the rendering provider, all those fun things, what the state had to do that, and what we had to do in the practice to do that. Those are certain conversations that could be engaged, and then what has to change from administrative side, rule advisory committee, versus getting those things in place so that those interventions could happen in the best practices, so that the actual engagement and the treatment could happen to what Anne is saying in a best practice way. You'd want all that done so that when it gets to the intervention stage, you can do what is a best practice to actually affect the improvement side of that measure, is basically what I hear you saying, Anne.
Yeah, that's because I think there's some of this we have to address up front. If not, I mean, I've worked in the CMHP for 9 years, right? I can tell you we're going to be dead on the water from the start without having those rules changed up front, because we can't have a peer go out and provide a service and keep doing that in a way that's unbillable and just hope it works out on the back end, right? We have to have some oversight up front and really get some processes changed up front. And yeah,
well, great. And it looks like you and Dana can have a conversation.
That'd be great. I appreciate that.
So this is not an either or situation. So it looks like potentially the IET could be explored further internally and externally as a conversation of a statewide PIP topic. Again, I'm not saying it is. I'm saying we're going to explore the conversation. I'm also going to explore access. I'm going to explore population health. Again, I don't know if there's I don't know if there's significant enough populations across all CCOs for that population, but there is some, it does relate very connectively to our health equity work as well, reducing disparities. And so I will be looking at that as well. I'm not sure about the greatest harm one right now, which is the fentanyl illicit drug, because I'm not sure from a reporting standpoint at the Medicaid level whether that's possible, but I do have someone looking into that. It's for homework. But those are kind of about I don't know, I think I named 4 to 5 broad categories I'm looking into. I've taken workforce off the table. I've taken 42 CFR off the table. Not that, you know, it's not an important topic. It's just not a PIP topic. It's a policy topic. It's not a performance improvement project. Workforce is an important topic, just not a performance improvement project. So we've got access, we've got IET, we've got potentially a population health in the pregnant, postpartum care, alcohol, other drugs, access, IET, pregnant women, harm related to illicit drugs. Those are kind of the 4, and there might have been a 5th. Hopefully Sarah's taking notes. Those are kind of what I'm exploring. What are people's thoughts? And once I get the homework from people, that will narrow us even further. And then maybe I'll do a poll. I might still do a poll. You know how we usually do a poll, just to really kind of see where the CCOs. And usually when we do a poll, just a reminder, I'll do a blanket poll to all CCO members, or not members, I'll do a poll to CCOs in which anyone in the CCO, quality directors, quality coordinators, medical directors, behavioral health, y'all can answer. And then when we narrow it even further, usually I ask for a second poll in which we get one CCO person. Y'all have to agree within the CCO. So right now I'm not asking you to agree within your CCO, but at some point I'll ask you to agree. So we'll probably send you a poll out with these kind of 4 or 5 basic broad categories, some of them very specific. We'll have Sarah work on that probably this week. And then I'll submit that poll. We'll see where you all are within the CCO. Everyone can, any QHOC participant, anyone in the CCO can submit their little vote. And then somewhere later this week, maybe towards the end of the month, once I get some of my homework, we'll probably even have you narrow down in which you might just get 1 vote at some point. Sound good, everyone? Does anyone want to put any other topic in the 4 to 5 broad bucket mix? Anyone want to add an elephant to the list? I'm just going to call them elephants, not oceans. Otherwise, you get the kingdom of Lisa and whatever Lisa comes up with. Okay, then I'm going to take the last few minutes to do items from the floor and then also talk about May. So for May, QHOC, in the afternoon session, first off, Laura, you might want to go on camera because I want to see your, so for May, I won't be here. I think you knew that. You did know that, right?
I knew that. You told me a couple months ago.
Okay, good. So I did tell you that, but everybody else on this call did not know that. So I have to pick up my daughter. I will be picking up my daughter from college. So I will be bringing her back to the good state of Oregon. So I will not be able to be with you all. So Laura will be your trustee chair running the meeting, and Sarah will facilitate the afternoon session. I may be able to join by phone, but I'm not sure. So I definitely won't be able to facilitate and remember much of what you all will say, hopefully. So Laura, I'm going to try and tee up a continuation of the IET learning session because it was some really rich information. Like they had some real practical workflows and knowledge that you should all take back to your practices. That would be the hope. So Laura, hopefully will, pretend you're in HSB in Salem, the lovely room that we all miss. Not really sometimes, but you'll whiteboard them through some kind of learning session with that rich knowledge of those participants. So I will try and tee them up for that conversation. Then we will also have an SUD design conversation that hopefully Sarah will continue to facilitate. So take the Lisa Bouye role and carry forward wherever the next few meetings have led to. So that will be the conversation. And yes, to David's point, if in fact the IET measure is selected, or the IET topic is selected as a statewide PIP topic, is there ways in which you can take IET for a statewide PIP topic and do things that you're not doing necessarily for the measure as the incentive measure, but kind of the improvement side of it, and bring it to bear with the statewide performance improvement. There is, David, but again, we have not made any definitive decisions on that, having had those conversations internally with leadership, et cetera, but I will explore those. I'm willing to have those conversations. We'll just see where those are at. So I won't be here for May. Laura will be here. You will also have, like I said, Sarah to lead you through the SUD conversation. And then I will also be bringing in the QA team into probably your June meetings for some more quality assurance, maybe Exhibit I conversations, that reporting template that you guys were talking about last time. Maybe they'll have a preview it. The other conversation is in June, you will all have, for a learning collaborative, childhood immunizations. So we were talking about bringing kind of a reset of, well, we're still in a pandemic, but coming out of the pandemic, hopefully, thinking through what we need to do to bring our health systems back up to around what should we do for our childhood immunizations, not necessarily specific to COVID, but all of our childhood immunization rates kind of took a hit. And how do we bring forth our systems up into that consciousness of all of our childhood immunizations. So we're bringing them in June to prep for anything you may want to do around kind of prepping for schools, start of school and all that. So that will be in June for the Learning Collaborative. Anything else?
Lisa, this is Tanvir. Just want to see if other CCOs want to share how they are doing, you know, nothing specific, but just in general on the AOD 1 and 2 measure for 2021. We were pretty close to targets. Yeah, it was pretty close. Yeah, it was.
Yeah, I think Tanvir, that's another good conversation. I was thinking, and I'll work with Laura. Laura, I'll send you the end of schedule, but I think it'd be good to map out when you guys want to do your TQS sharing, where you bring a project to the floor, you know, where we do breakout rooms. And then I think it'd be good to do another sharing on your PIP topics, where so I just heard, which I'd give a shout out. I don't know if Linda's on or Caleb's on from IHN. We just did a conversation with CMS on maternal health and the doula program that they tested out in IHN. I made it sound like they tested doulas. That sounded horrible. They did a particular community-based program with doulas in their IHN membership, and CMS will be, and CMS asked about it, and so we just talked about that. It was related to one of their PIPs and TQS work, and so I wanted to again talk to you all about the correct timing or the appropriate, and Laura and I will work that out, when to do a TQS project sharing and a CCO specific PIP project sharing, because it's with those specific PIPs and with those specific TQS projects that you guys have some really cool things going on that y'all should, you know, one, highlight just because they're just awesome, but learn from each other on. So we will time those out and then let you guys appropriately plan, so you can pick the topics and then do breakout rooms and some lessons learned. We'll probably do one of those in June, maybe August, I think is when we did the TQS. I think that's what we did last year. But so we'll probably do one in June and probably August is my guess. PIPs and then TQS in August.
And Lisa, from a metrics standpoint for 2022, and I don't know what the plans are with the metrics and scoring committee for 2023, but there are these two ECQMs within the measure set, and one of them is a cigarette smoking prevalence measure. The other one is SBIRT. Both of these are non-CMS specifications. Like the diabetes is CMS specification, hypertension we report on, and depression as well. But these two, SBIRT and cigarette smoking prevalence, are non-CMS, and they are causing a lot of issues from gathering and getting the right data set from the EMRs for CCOs in general. So we will be good to kind of update us all. What are the constraints I know benchmarks and targets that if you change the measure, drastically from a specification standpoint, then you've got to set those benchmarks and takes a little time. But other than that, what are the constraints? Why can't we just transition to a CMS level specification for these two, cigarette smoking prevalence and SBIRT?
Tanvir, I think that would be definitely a good question for the technical advisory group, but we can definitely get that over there. When I say get it over there, I'll connect with the analytics folks and make sure the question is routed to the appropriate. And then if there's a follow-up that needs to, just get double communicated, cross communicated to both audiences, then I can make sure to cross communicate in the QHOC audience as well as the metrics and scoring / metrics and scoring tag technical advisory group. Does that sound good, Tanvir?
Perfect. That'll be perfect. Thanks.
Okay. Any other questions from y'all? Again, any topic? Well, any quality topic? Okay, well then you will get a pretty big follow-up email from me related to the morning session and the afternoon session. We'll start packaging that up. Sarah will help facilitate the SUD May session with you all. We will see some of you at the 4th of the month session with me. We'll try and collect some of the homework and have some of these internal conversations. You'll most likely all, if you're on this QHOC meeting, get the polling, just generally speaking, like what's your feeling on the following, rank them. And then Laura will be your trustee facilitator for the QPI session in May. As always, just email me if you have any random thoughts, but otherwise enjoy the weird weather of Oregon, and I will see you all at some point. Thank you all.